Thank you for coming to this lecture series. This is the Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. It qualifies you for 3 hours of Louisiana Opioid CME credit. We are going to divide this series into 6 segments. The first half will be Solving America's Prescription Epidemic, and the second will be Update 2018 and Best Practices in Prescribing and Managing Controlled Substances. We're going to divide the first segment into 3 parts: opioids in the brain, provider roles in combating the epidemic, and the care pathway for the prevention of addiction, and then finish up with opioid stewardship at Ochsner. And in the second lecture, we're going to talk about the opioid epidemic trends in 2018 and what all of the healthcare regulatory bodies are saying. Then we'll talk about best practices with pain, opioid dependence, and addiction, and intentional withdrawal, and some provider internal skills. And then we'll finish up with diversion. So let's start with Solving America's Prescription Epidemic, Part 1, where we'll talk about the epidemic and opioids in the brain. Let's get started with a case presentation. This is a true story. A 32-year-old male presented to the emergency room at Baptist Hospital with a history of Crohn's disease. He was a Gulf War veteran who said he was discharged from the Army for uncontrolled symptoms. He was unable to get relief for his symptoms at Walter Reed Hospital in Washington, D.C. So he left that hospital and he tried several hospitals in just about every state along the East Coast, going south, until finally he landed at Baptist Hospital in New Orleans, right after it reopened post-Katrina. He was admitted, and it was discovered that he had fictitious diarrhea induced by taking magnesium citrate in his hospital room. By that time, we had a chance to observe him, and his diagnosis was obvious. Advice was given to him to seek help for his post-traumatic stress disorder and for his addiction. This caused him to become angry. He left against medical advice. 2 weeks later, he returned, and this time he had a large open scar on his abdomen. Upon questioning him about this, he reported that he caught a military cargo jet. He actually left New Orleans, went to Washington, D.C., caught a military cargo jet, and went to Frankfurt, Germany. There, surgeons removed part of his colon. After surgery, the wound popped open, he said, so he came home. Later, after we were treating him, he told us that the wound, he had actually opened the wound so that he could convince the surgeons to give him more Dilaudid, but they didn't buy it, and they just discharged him. So when we admitted him that time, the second time, we advised him to give him proper treatment for post-traumatic stress disorder and addiction, and withdrawal was recommended, and he agreed. Surgery was consulted for proper wound care. He was withdrawn from opioids over 5 days. Arrangements were made to send him back to Walter Reed for ongoing psychiatric and addiction care. So I chose this story because it demonstrates several things. It demonstrates fragmentation in our healthcare system, and a healthcare system that's not empowered to rescue the addicted patient in need. It demonstrates a lack of communication between healthcare systems, and it reveals what lengths a patient will go to satisfy their addiction, even leave the country, even mislead their physicians, or even undergo unneeded surgical procedures. It demonstrates that neglecting the addiction only makes the psychiatric problem worse and sends the patient on a downward spiral towards iatrogenic complications. This case reveals system pathologies that need to be corrected. And a patient like this, who's willing to give his life for his country, deserves to come home to a national healthcare system that can rescue him and help him when he is psychologically vulnerable. So let's start by talking about history of opioids in the United States. In the 1860s, we had our first U.S. opioid epidemic, which occurred after the Civil War. It was called soldier's disease, and doctors called it morphinism. In the 1900s, we had our next epidemic. Heroin was extracted by the Bayer Company in Germany, and they marketed it as a non-addictive alternative to morphine. Well, this led to the Harrison Narcotic Tax Act, and then it led to making heroin illegal in this country. Then in the 1970s, in the post-Vietnam era, we had another illegal heroin epidemic. We did not have a prescription epidemic at that time. And then later, in the 80s, the war on drugs was declared by Ronald Reagan. In 1986, Dr. Russell Portnoy published a retrospective study of 38 chronic pain patients. And he suggested that chronic pain could be treated with opioids in that review. 2 years later, in 1988, the Purdue Pharmacy Company used that study to aggressively market their new product, OxyContin. They hired physicians to sit on pain advocacy boards and lobby congressmen and state legislatures with pain advocacy committees. They eventually got the Federation of State Medical Boards to release a policy that physicians would not face regulatory action for prescribing opioids. And then in the 2000s, the Joint Commission got involved. They actually published a book that stated that opioids were non-addictive. And they created the fifth vital sign and then made that a Joint Commission requirement. And later, pain management became a patient right. In 2000, Congress declared that 2000 to 2010 would be the decade of pain control and research. Basically, they conducted an experiment by pushing low-quality evidence onto the American healthcare system. So all this activity caused the pendulum to slide back and forth between not using opioids and accepting some discomfort and helping patients to manage their pain, to using opioids to eliminate all pain and not worrying at all about the psychosocial needs of the patient. By 2008, the results of the decade of pain control and research turned out to reveal that opioids don't actually work for chronic pain. And they still are useful for short-term acute pain. And that opioid-treated chronic pain patients demonstrated higher pain scores versus non-opioid users, decreased quality of life and employment, increased disability and healthcare utilization, and side effects, including hyperalgesia. So what is the mortality data showing? Mortality is only the tip of the iceberg. It's not revealing the true tragedy, which is morbidity, the ruining of people's lives, but it is a way of measuring progress. In 2016, there were 64,070 overdose deaths in the United States. There were more deaths than breast cancer deaths, and there were more than car accident deaths. And this is more deaths than U.S. military deaths in the entire Vietnam War. Now in Louisiana, we had 305 deaths. And in 2015, there were more prescriptions written than we had people in our state. Louisiana is the 6th highest prescribing state in the country. Now in New Orleans, we had 211 deaths in 2016. To put that in perspective, there were 175 murders that year. Now, in April of last year, the Louisiana Commission to Prevent Opioid Addiction convened, and I took some of the facts that they reported in their report out for you. Opioid abuse costs Louisianans $296 million per year in healthcare cost. And Louisiana ranks 50 out of 50 states in the United Healthcare Foundation's report, America's Health Rankings 2015. This ranking is consistent since 2009. And two of the three primary drivers for poor health are directly influenced by the opioid epidemic, and they are HIV and drug-related mortalities. 6 states prescribe more than Louisiana: Mississippi, Alabama, West Virginia, Oklahoma, Tennessee, and Kentucky. Over the past 6 years, Louisiana has averaged 122 prescriptions per 100 people. In Louisiana, males outnumber females in the rate of opioid overdose deaths, and whites outnumber all other ethnic groups. And in 2015, suburban populations, Livingston, Washington, Plaquemine, Terrebonne, Orleans, St. Tammany parishes led the state with overdose rates that were at least 50% higher than the rest of the state. And St. Tammany averages about 50 deaths per year, and Jefferson 55 deaths per year. That is, they have the highest number of overdoses. So why is this important? This is important because in the past, we've not done a good job of assessing risk of addiction. And now we face this epidemic of opioid overuse, overdose deaths, and overutilization of healthcare services. As healthcare institutions cut back on their prescribing, patients transition to heroin. Louisiana does not have a heroin problem compared to other states yet. The cardinal features of this epidemic are diversion of tablets, addiction, chronic pain, psychiatric illness, and overutilization. How are these things related? They are related by 2 things: human brain physiology and function, and by American culture. All these things positively reinforce one another. This epidemic is a cultural pathology. It is exclusively an American phenomenon. It does not exist in Europe, Canada, Asia, India, Australia, Central America, or anywhere else on the planet. The opioid problem is a healthcare system problem, and it requires a healthcare system fix. In answering the question, how are we going to fix this epidemic, we now look at our patient's brain function. Basically, we have 2 overlapping systems in the brain called the learning reward system and the pain matrix. The learning reward system controls Pavlovian learning and pleasure and connects intimately to areas that control judgment, memory formation, and emotional control. And over time, with exposure to opioids, the learning reward system turns into the addiction pathways. Opioids usurp the normal learning and emotional control pathways, causing impulsive behavior. Now, the pain matrix on the right. The pain matrix is part of the brain that processes nociceptive stimuli. It has a 3-tiered processing system, and it overlaps with the addiction pathways. So what is addiction? Addiction is an acquired disease of the brain that persists long after the last use of the drug, and is produced by repeated pharmacological insult. It is a pharmacologic-induced change in brain circuitry that strengthens learned drug-associated behaviors at the expense of adaptive responding for natural rewards. So let's talk about the brain disease model of addiction. The ventral tegmental area and the nucleus accumbens are the learning and pleasure centers of the brain. This is where Pavlovian learning takes place. It makes sense that pleasure and learning would be together in normal circumstances. In order to stimulate a remembrance, the pleasure signal entices the human to repeat the action. So when a kid learns something new, there's a dopamine flash in those 2 areas, followed by a weak dopamine signal to the prefrontal cortex. Dopamine release in the prefrontal cortex then begins to make connections with cortical nerve fibers, and that's to create memories and to provide memory feedback loops over that structure on the bottom called the amygdala. The amygdala is the emotional control center of the brain. and it's not mature until age 24. Without prefrontal control, the amygdala will tip the balance of behavior towards impulsive actions. Now with opioids, there is a dopamine blast instead of a healthy, pleasurable flash. And the result is euphoria. The brain responds with several adaptive changes, both intracellular and within the synapse, depending on the drug. The net effect is the same, to reduce the effect of dopamine in the ventral tegmental area and the nucleus accumbens, so that more drug is needed to get the same effect. A dopamine blast also surges up to the prefrontal cortex, and a large amount of dopamine is released between the prefrontal cortical fibers and the cortical fibers. There is another adaptive response by the brain, and that adaptive response ends up in reseeding of dendrites there. And that halts new memory formation, and it disconnects control over the amygdala. So inability to achieve academically, progressive psychiatric disorders, and lack of impulse control is the result. Now, the brain disease model of addiction is fully established in science. It is not a theory. Lack of behavioral control is a pharmacologically induced phenomenon, and we doctors have the prescription writing power. Every time we use these drugs, we are injuring brain tissue, and we are endorsing impulsive actions throughout our community. Every time you prescribe to a sweet little old lady, you're putting her grandchildren at risk. And since this neuroplasticity is permanent, addiction should be viewed as a chronic relapsing disease, not as an acute episodic illness. The transition stages of addiction are social use with first exposure. Then it moves to regulated relapse, which is conscious. And then it will progress to compulsive relapse, which is unconscious behavior. That's when it's formed fully into a habit. And then since I'm a hospitalist, I added the palliative phase because we see these patients in the hospital over and over again at the end of their lives. First with non-hospice palliative care, and then it will ultimately go to hospice. Now, before we go to the pain matrix, let's talk about chronic pain. What is chronic pain? Chronic pain is not the same thing as acute pain. It is pain greater than 3 months. Chronic pain is associated with fear and avoidance behaviors. It leads to and it overlaps with opioid dependence. Chronic pain needs attention to psychosocial factors. It is treated differently than acute pain. Chronic pain needs a multimodal approach for treatment. Now, we need to measure functional status rather than the fifth vital sign for chronic pain. The goal of therapy is to improve the patient's functional status in the setting of pain. The goal is not pain relief. There is no high-level evidence that opioids actually help chronic pain, but there is evidence that opioids worsen chronic pain. The incidence of chronic pain has increased in the last 20 years despite the widespread use of opioids. There are two main pathophysiologic mechanisms for chronic pain. Central sensitization results from neuroinflammation that occurs in the brain and spinal cord, particularly in the midbrain structures, the periaqueductal gray zone and the rostral ventral medulla. In there, microglial cell activation causes the release of cytokines, interleukins, and glutamate, and that causes cell death. It leads to mental dysfunction and depression. And the second mechanism is a dysregulation of descending modulation by glial cells that takes place in the dorsal horn of the spinal cord. Now, the pain matrix includes all parts of the brain that control and modulate sensory input, which comes from the dorsolateral spinal thalamic tracts. It is a constellation of brain regions a multi-level hierarchical neural network, which creates a pattern of neural activation that represents the pain signature of the experience. Sensory information is continuously streaming in. The brain has to first interpret it and then place meaning onto it and then reflect it back to the original source. So first, the nociceptive input arrives at this green blob, which is the thalamus. And then it is interpreted in the perceptual attention areas of the cortex. This is conscious modulation. And then it is reflected to the emotional areas, where importance can be applied to the information. And this is unconscious modulation. After the sensory input is altered by these three filters, descending modulation of the pain signature occurs. The pain signature enters the periaqueductal gray zone and can be inhibited there or facilitated there, either toning down the pain response or increasing it. Then the altered signature enters the rostral ventral medulla before it passes back down to the dorsal horn. Now, normally, after the pain signature is reflected back to the original source, in the brain, it begins to de-intensify, both with time and with distraction. But with opioids, there is a different story. Opioids work by turning off the reflection of the pain signature at the level of the periaqueductal gray zone and the rostral ventral medulla. There are a lot of opioid receptors in those two structures. Opioids have also been shown to disrupt the function of glial cells in there, and that intensifies the neuroinflammation, causes the spontaneous firing of neurons, causes central sensitization, and leads to hyperalgesia and chronic pain. So let me repeat the gist of that statement. Opioids intensify neuroinflammation in the periaqueductal gray zone, the rostral ventral medulla, and the dorsal horn, causing central sensitization. Now, at the same time, opioids are also intensifying the pleasure signal. Opioids reinforce the memory of the pain matrix signature by increasing dopamine in the nucleus accumbens in the ventral tegmental area, thus increasing the pleasure signal at the same time as the painful event. So let me repeat the gist of that statement. Opioids reinforce the memory of the pain matrix signature. Now, when they wear off, on one hand, the periaqueductal gray zone and the rostral ventral medulla release the signal, and on the other hand, the pleasure signal also disappears, and pain perception for the patient actually gets worse. With repeated use of opioids, all of those maladaptive neuroplastic changes that were seen in the addiction pathways progress over time, and that adversely affects prefrontal control over both the amygdala and the periaqueductal gray zone, and that leads to highly emotional patients in constant pain. It's a no-win situation to use opioids in the long term. Less is always more. The shorter the therapy, the better off your patient is, so that his or her brain has a better chance to heal the neuroinflammation and forget the pain signature. When it comes to proper brain function, forgetting is just as important as remembering. Now, the learning reward system and the pain matrix are connected by shared neural networks. These anatomic regions overlap in the conscious and in the unconscious mind. Connectivity mainly occurs in the prefrontal cortex and the nucleus accumbens. The periaqueductal gray zone sits right next to the ventral tegmental area, and it receives input from the prefrontal cortex, insula, and many other important structures. The fourth cardinal feature of this epidemic is psychiatric disorders. The relationship between chronic pain and psychiatric illness is bidirectional. Chronic pain leads to depression, and depression leads to chronic pain. It goes both ways. And we know that there are associations between chronic pain and psychiatric disorders, and we also know that opioids affect the modulation of pain and they lead to addiction. These three things are intimately entwined in the brain. And evidence for this is based on functional MRI imaging studies and epidemiologic studies. In clinical practice, we see these three things, chronic pain, psychiatric disorders, and addiction together, and they cannot be separated, despite the fact that we have different specialties and separate DRGs for all these conditions. So we need a non-opioid treatment that addresses both chronic pain and psychiatric disorders at the same time. And this brings us to the biopsychosocial model of pain. Now, the fear and avoidance model, which is within the biopsychosocial model, is a widely recognized and well-studied theoretical construct that is used to explain how psychological processes in the brain mediate the transition from acute pain to chronic pain. Treatment is cognitive behavioral therapy, acceptance therapies, multidisciplinary pain rehabilitation, psychopharmacological treatment like SNRIs, tricyclic antidepressants, and anticonvulsant medications. The good news is there is a treatment, and treatment is evidence-based and it's rooted in science. The bad news is that the treatment must be systems supported, which is why we're all here learning about this. Now let's talk about central pain and central sensitization. Central pain occurs when direct injury to nerve tissue happens in the brain itself, and the brain creates its own pain signature. Glial cells are the resident macrophages of the brain, and they secrete the cytokines, interleukins, and glutamate, and that causes the firing of neurons, cell death, and depression. As you can see, these are several medical conditions that cause central pain, and hangover is on the list. Hangover is caused by a neurotoxin, which is alcohol, that causes the release of glutamate in the brain. And it takes about 8 to 12 hours for that glutamate to wash out and for the hangover to go away. That's a form of central sensitization. Imagine pain syndrome that would not go away. That is what central pain can feel like. Another major cause of central sensitization is opioid use. Opioid withdrawal pain, hyperalgesia, allodynia, analgesic-induced headaches are all forms of central sensitization. And chronic pain syndromes like back pain, osteoarthritis, fibromyalgia can also cause central sensitization. The point here is to suspect when opioids are failing to bring relief that you could be inducing central sensitization and causing opioid-induced pain. It could be a complication of your opioid therapy. Now, proper treatment for central pain and central sensitization includes an anti-seizure medication, a tricyclic antidepressant, and an SNRI. These are the three that I tend to use first, but the others are also effective. Now, you need to also do the non-pharmacological treatment. And non-pharmacological treatment for central sensitization, I like to divide it up into the conscious mind and the unconscious mind. Now, for the conscious mind, you need to appeal to their sense of education. You need to start cognitive behavioral therapies and acceptance therapies. You need to teach patients how to recognize and avoid their unconscious impulses. And you need to teach them coping skills like serial relaxation, deep breathing. Deep breathing is the #1 pain reliever in the world. That's why we use it in pregnancy. It works. We also need to teach patients to recognize their fear and avoidance behaviors and recognize pain catastrophizing behavior. Now, for the unconscious mind, we want to use distraction. And the biopsychosocial approach and functional rehabilitation programs are full of methods of distraction. And there's a lot being done right now to look at different methods of distraction, like virtual reality. Pediatricians have been using distraction for years when they place IVs in small children. This is something that we really need to consider when we're treating our patients who have chronic pain. Now, this concludes the first segment of the Opioid Stewardship Physician and Provider Education Program at Ochsner Health System. In part 2, we're going to talk about provider roles in combating the epidemic, the care pathway for the prevention of addiction and risk assessment, including the opioid risk tool, and then we're going to talk about our group and system responsibilities. Thank you. Welcome back to the Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. This is the second part of the first half, Solving America's Prescription Epidemic. In this segment, we will discuss provider roles in combating the epidemic, the care pathway for the prevention of addiction, the risk assessment, including the opioid risk tool, and our group and system responsibilities to patients. So how are we going to get this done? With this slide, we're trying to look at the community-hospital system relationship. This slide demonstrates what we have been doing in the past and what we need to do in the future. It shows how we are now operating by overprescribing and encouraging the flow of patients from the community into the hospital system. Presently, patients are caught in the middle, bouncing around from ED to clinic to hospital with no real treatment options for their chronic pain or their addiction. They're just looking for anything that will treat their pain. They don't understand why they have pain, they just hurt. Our new goal is to reverse the process by providing evidence-based treatments for both chronic pain and addiction, which is a multimodal approach, and move patients back towards the blue area, towards independence and self-management. We also want to prevent new cases. Our job as physicians is to sort this out for the patients, to correctly diagnose them, and to provide guidance towards real relief. We need to stop overprescribing and use alternative methods for pain relief. Now let's talk about provider roles. This epidemic can only be solved with teamwork. For primary care physicians will play the role of prevention. They need to use evidence-based treatments for chronic pain and transition acute pain patients off of their opioids quickly. They need to help the patient seek alternatives for pain relief and use the biopsychosocial model of care. They also need to address psychosocial factors and steer the patient towards functional restoration programs. They need to manage chronic pain and manage opioid contracts. And some primary care physicians need to get certified to prescribe Suboxone for their long-term opioid-dependent patients. Psychiatry. Hospital systems need to expand psychiatry services in general. The Substance Abuse and Mental Health Parity Act has provisions for both the treatment and the payment for mental health and substance abuse. This epidemic has spurred off other epidemics of a variety of psychological diseases, and they need national attention now. Suboxone maintenance programs and cognitive behavioral therapies need to be expanded both in the inpatient and the outpatient setting. Hospital medicine. Hospitalists will play a role in withdrawing patients who have complications from opioid therapy. They need to start chronic pain regimens. For complex patients, hospitalists may need to convene a multidisciplinary team, and that could include the patient's nurse, therapist, pain management physicians, primary care physician, psychiatrist, patient relations, and hospital management, and even security. This group will need to form a long-term care plan. And in that plan, direction can be suggested for the ED provider, the rehab provider, and the primary care provider. Patients who have complications of opioids, patients who fail opioid therapy, patients who have evidence of misuse should have their opioid use discontinued. Functional status needs to be measured objectively daily in the hospital, and aberrant behaviors need to be documented by all providers to assess progress. Now, pain management physicians. Pain management physicians need to take the hospital system lead, especially with provider and administrator education on the proper chronic pain management, including both the pharmacologic and the non-pharmacological treatment. They need to assist primary care providers in chronic pain treatment, and they need to provide alternative therapies for pain relief, such as IV lidocaine, inhaled nitrous oxide, IV propofol, IV ketamine, IV Tylenol, liposomal bupivacaine injections, and perineural catheters with IV ropivacaine. All of this needs to be expanded and made readily available in the hospital setting. Now, ED providers. ED physicians play a role in treating overdose, of course, but they need to communicate these complications to the prescriber. There is no role for treating chronic pain in the ED. And ED physicians, just like the rest of us, need to make and check chart flags, need to look at the opioid risk tool, need to look at the prescription monitoring program and screen those patients, and also need to look at and do much more urine drug testing. ED physicians need to refer patients to addiction treatment straight from the emergency room. Now, not on this slide, but just as important, are surgeons, subspecialists, and this includes dentists. These providers need to seek out alternatives for opioid therapy and reduce the use of opioids as much as possible, recognizing that patients who undergo procedures always need excellence in pain relief. They should not refill medications for chronic pain and refer those patients back to the appropriate prescriber. Now, preoperative evaluations for opioid risk need to be done because not every patient has the same risk. And it is understandable that in some cases, opioid therapy cannot be avoided. But weaning and stopping the opioid therapy is the responsibility of the provider who initiates it, and the care is not complete until that task is done. Now, here is the care pathway for the prevention of addiction. The key to understanding this disease and to preventing opioid dependency and substance use disorder is to understand that this is actually one disease process. It is a progression of pathology which correlates with anatomical and functional changes in the brain. The top of this slide represents the progression of the disease. And with ongoing use of opioids, patients can progress from acute pain to chronic pain to opioid dependency to addiction and then substance use disorder. And we need to prevent that. So quickly, let's look at each one of these. Acute pain. If you had a tool that told you which patients were going to have problems, wouldn't you want to use it before surgery? Well, we have one. It's called the opioid risk tool. Chronic pain. As we already stated in the previous segment, chronic pain needs a different treatment approach. It's not the same thing as acute pain. Opioid dependence is a complication of opioid therapy. It signifies neuroplastic changes in the brain have already taken place, and it can start as early as 5 weeks. It's associated with tolerance, withdrawal symptoms, emotional liability, impulsive behavior, and aberrant behaviors like running out of tablets early, misuse, and doctor shopping. It could be either iatrogenic or social, or it could signify an underlying attachment disorder or an underlying psychiatric disease. Opioid dependence is preventable with appropriate treatment for chronic pain. So patients need to be informed about the risk of opioid dependence before we prescribe opioids to them. And healthcare systems need to build in structures that aid in the prevention of opioid dependence. Now, addiction. Addiction is a late complication of opioid therapy. It is the pursuit of substances for no medical reason despite harm. It signifies advanced neuroplastic changes involving the prefrontal cortex, the motivational reward system, and the midbrain pain pathways. But conscious executive functions, that's the temporal lobes, they remain intact. So symptoms include loss of unconscious control, like poor judgment, difficulty learning, and impulsive behavior. So patients can be sincere and unreliable at the same time, and that's the hallmark of addiction. It progresses to substance use disorder, like heroin use. Now, the vertical columns on this slide help you get started on a treatment path. There is a lot of overlap. And as we said, evidence-based medicine for chronic pain is both pharmacologic and non-pharmacologic. The offending drug needs to be removed. These patients need attention to psychosocial factors, and fear and avoidance behaviors need to be managed appropriately. And often, their anxiety is opioid-induced. Adding the benzodiazepine is the wrong thing to do. It makes their addiction worse, and it increases their risk of overdose. These patients need reassurance and a lot of contact with their provider. Now, treatment for opioid dependency includes everything in the chronic pain pathway, or in that column, plus the need to transition your patient through a period of intentional withdrawal. Now, this is tricky, of course, because you want to get the patient's buy-in. But when patients come to the hospital with complications, it's often a wake-up call, and they are willing. Complications of opioid therapy make it necessary to stop it, and usually the family is supportive. Sometimes families can be enabling. If this happens, you need to bring them in, you need to talk to them, you need to figure it out and educate them if possible, and get them aligned towards the right care. Now, I'm sure this is much harder to accomplish in the outpatient setting, so a more subtle approach is needed, and perhaps it can be done over more time and gradually. Now, addiction. Addiction needs good psychiatry care and good follow-up, and usually there is an underlying psychiatric disorder. In patients without an underlying psychiatric disorder, the ones who have a pure iatrogenic opioid dependency, well, they're much easier to withdraw, and they're less likely to relapse. But addiction that is an attachment disorder will need long-term social or family support. And without that support, they often fail and they come back to the hospital. Now, some patients with addiction can be withdrawn and they can maintain abstinence with that good social support and close physician monitoring, such as weekly urine drug screens. And some will need long-term maintenance therapy with Suboxone or medication-assisted therapy. These patients will all need long-term psychiatry care. They will require long-term counseling, cognitive behavioral therapies, group therapies, and sometimes you may need to build a whole new social support system for them. They may have to move out of the neighborhood into another neighborhood or even into a new city. They can return to a functional life and they can hold jobs. Now, if treatment fails, if treatment of addiction fails, it leads to recurrent infections, recurrent admissions, endocarditis, spinal abscesses, end-stage renal disease, limb loss, and ultimately it becomes a palliative care situation and then hospice. So how do you know where to place patients on this slide?
These are the 5 A's of analgesia therapy. This is the mnemonic used to remind providers on what needs to be monitored while they're prescribing opioids. So the first A is activity, which is the patient's functional status, their ADLs, and other activities such as sleep and eating and ability to work and function at home. The second A is analgesia. This is their subjective pain score, what they feel and perceive. The third A is adverse effects or side effects, such as nausea, vomiting, constipation. The fourth A is aberrant behaviors. These are behaviors that are dysfunctional, they lead to misuse and abuse, behavioral disturbances. All providers need to monitor aberrant behaviors in patients who are prescribed opioids. And the last A is effect. This is any change in the patient's psychological condition, such as mood or anxiety.
Well, first you need to assess their risk. Risk is defined by the physician's clinical judgment after reviewing the following things. Results need to be taken in the appropriate clinical context. A proper risk-benefit analysis includes the opioid risk tool score, then a pain history, an opioid history, and a psychiatry history, then the urine toxicology screen, and a check of the prescription monitoring program, and then a look at their current morphine equivalent daily dose. These other things on the bottom just help clarify the diagnosis even more. Now, the opioid risk tool is the initial screening test. It's a brief screening tool. It represents the past opioid history, the past family history, the past psychiatry history, and the past child sexual abuse history. And it's hidden behind a number value. It is the minimum standard of care. Less than 4 indicates low risk. Everything else needs a more in-depth risk-benefit analysis. Now, the opioid risk tool score is discrete. So just seeing a number of 9, for example, will tell you that this patient has significant psychiatric disease or significant risk factors for opioids. And it's derived from 5 questions. Now, if the opioid risk tool is greater than 3, then these other things in the middle row will need to be checked. So without an updated history, and I mean a opioid history, pain history, and psych history, admitting physicians often miss the correct diagnosis. And the PMP will screen for doctor shopping, pharmacy shopping, and clarification of what's actually being given to the patient. And the urine drug screen will screen for other substances, for compliance, for diversions, for substance use disorder. And the 24-hour morphine equivalent daily dose, well, if it's greater than 90, that patient is automatically in a high-risk category for overdose. And if they take benzodiazepines with the opioids, they are automatically in a high-risk category. And those patients need a prescription for naloxone. Now, these boxes on the bottom help stratify the patients even more. They provide more evidence for opioid dependency or addiction. Opioid complications, aberrant behaviors, and adverse late drug effects should be documented to justify your decision to recommend cessation. Now, just to review the side effects of opioids. The most confusing one, believe it or not, is nausea and vomiting, because nausea and vomiting can be several things. If it happens right after you give the opioid to a patient, well, that's a side effect. But if it happens 2 days after discharge from the hospital and they're coming back with nausea and vomiting, that's withdrawal. Recognize the symptoms of withdrawal. And be aware of the clinical context in which nausea and vomiting presents. Now, if you see nausea and vomiting chronically, and they keep coming back with it, then you need to start thinking of gastroparesis, opioid-induced gastroparesis, or narcotic bowel syndromes, or cyclical vomiting syndrome. Opioids are contraindicated in all of these. To recognize the late complications of opioids. Now, the next 2 slides, these 2 slides will list the aberrant behaviors, or some of the aberrant behaviors. These should be documented by all who contact the patient, the doctors, nurse, therapists, management, even security. And this is to demonstrate that the team is working together to monitor the patient's pain-related behavior. and the patient's psychiatry behavior, and the patient's functional status. Documentation of aberrant behaviors protects you medically legally in the chart and explains why opioids need to be stopped. Now, you also need to calculate the 24-hour morphine equivalent daily dose. So you want to convert all of their various opioids, whether it's IV or oral or patch, to oral morphine, and then add up the total. And you can use the medical calculator online to make it easy. We should all do it the same way, from 7 a.m. to the previous 7 a.m. So we come in the morning and we can see what our patient did the previous day. This is important when we're weaning patients to measure progress, so we can match their morphine equivalent daily dose with their functional status and with their aberrant behaviors. Now, if their morphine equivalent daily dose is greater than 90, that's considered high risk, and they will need a prescription naloxone. This is what the morphine equivalent daily dose calculator looks like in Epic for the clinic. This is used for outpatient prescribing, and the morphine equivalent daily dose will be located above the opioid in the discharge prescribing menu. Epic is building one for the hospital that hopefully we're going to be able to incorporate soon. Now, late effects of opioid drug effects include tolerance and physical dependence and, of course, addiction. If we see any of these things and our patients are not end of life, then we need to address it. We need to make every attempt to wean the opioid to the lowest possible dose or discontinue the opioid if possible. And if not, then they're going to need medication-assisted treatment. These other two things on the bottom are complications of patients who have end-of-life pain, and we've committed them to lifelong opioid therapy, and they must take opioids. So if they're having trouble, then we may need to increase the dose, understanding that we are progressing them towards hospice. So what is the opioid risk tool? The opioid risk tool is only part of the risk assessment. We know that it misses some patients. We are using it as a means to capture more patients for screening and to communicate with one another better than we have in the past. And perhaps one day it will be replaced with something that is more thorough. But for now, this is what we're using. It addresses 5 elements: personal history of substance use, family history of substance use, history of psychological disease, age, and history of pre-adolescent sexual abuse. The opioid risk tool can be used as an interdepartment interest system communication tool. By having it display above the opioid in the medication menu of Epic, it will become a stop, pause, think measure. If you see it, and that means the score is greater than 3, and it alerts the provider that a full risk-benefit analysis needs to be performed. It is determined by previous providers, and it communicates risk in a sensitive fashion from visit to visit, from previous physician to present physician, from outpatient setting to inpatient setting, and from psychiatrist to ED doctor to hospitalist, and every which way. So what is our group and our system responsibility? We must screen patients because failure to do so places the patient at a lifetime risk of addiction. Validated tools and evidence-based methods are reflective of the reality that our patients are facing in the population. And the screening needs to be incorporated into routine clinical practice. It is a minimum standard of care that risk of addiction should be assessed prior to giving opioids to a patient, and the opioid risk tool meets that minimum standard. Evolving cultural pathology requires new standards of care and new modes of communication. Healthcare systems must address gender biases, and providers need to develop easy-to-use, discrete, tools and standardized scripts to help them address their discomfort. This is what the opioid risk tool looks like in EPIC. If the score needs to be generated, this tool will pop up and this form needs to be filled. This occurs on the first time a patient is being prescribed opioids at Ochsner Health System. When you fill this form out, you are informing your colleagues of the patient's opioid risk. Now the patient's sensitive history is communicated through a number value. The tool will automatically calculate the score. Here are the questions and the points assigned and the original paper with the reference on the bottom, and it's on the next page as well if you want to look it up. The main difference is that in men, more weight is assigned to family history because genetics plays a greater role in men. And in women, more weight is assigned to that pre-adolescent sexual abuse history because that has more significant weight in women. So for this study, abuse was defined as deliberate overuse. And low-risk patients predicted that 6% would go on to display aberrant behavior and be unlikely to abuse opioids. And the high-risk patients predicted that 91% would display aberrant behavior and be more likely to abuse opioids. So we're using this tool to rule out the low-risk patients. So in summary, if you take anyone with pain and evaluate their opioid risk properly, you should be able to place them somewhere on this chart. This will help you understand where they are in the progression towards their addiction and help you get the proper diagnosis and steer them towards the appropriate medical and psychosocial care. Remember, make the proper diagnosis. Help your hospital administrators, the government, and insurance companies to monitor these patients and target them for care and provide resources for them. This concludes the second segment of the first half of this Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. The next segment will be about Ochsner's efforts to combat the epidemic. Thank you. Welcome back to the Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. This segment is part 3 of the first half, Solving America's Prescription Epidemic, and we will talk about opioid stewardship at Ochsner. We're going to start with a case presentation, and this is a true story. A 43-year-old female was admitted for a pneumothorax related to sarcoidosis. It was difficult to manage, and it resulted in a prolonged ICU stay and 6 chest tubes over 2 months. After removal of the last chest tube, the patient was transferred to the hospital medicine service. Her IV pain medication was converted to oral therapy, but the oral morphine equivalent dose was increased to ensure analgesia. The patient expressed anxiety related to that change. She required a long stay in the skilled nursing unit after hospitalization for deconditioning, and there she was maintained on long-acting opioid therapy. She was discharged and sent to a new primary care physician who immediately became alarmed at the high opioid dose and initiated a pain contract and a plan for gradual withdrawal. The dose was lowered in a stepwise fashion. But the patient switched primary care physicians, and the second primary care physician maintained her medication and refilled it at the same morphine equivalent daily dose from then on. A year later, the patient was admitted to the hospital for nausea and vomiting and was found to have opioid withdrawal due to running out of her tablets ahead of schedule. She was placed on IV Dilaudid in the emergency room, and her symptoms immediately improved. The following morning, she was reluctant to change her oral medication, and she threatened to call patient relations and directed aggressive verbal remarks towards the resident physicians. The next day, the medical team actually changed staff physicians. And the second staff physician called a multidisciplinary team, and that included the nurses that were taking care of her, therapy, all physicians involved in her care, the administrators from patient relations, and the primary care physician was updated by phone. When the staff entered her room, it was apparent that the patient was very anxious. The staff physician addressed her fear with the first sentence by stating, "I just looked at all of your x-rays, and the pneumothorax is gone. It has been over a year and has not come back. You are stable." The patient immediately felt better and then asked, "Then why do I still feel pain?" This opened a friendly conversation about the pharmacology of opioids, including the long-term late effects, including hyperalgesia. Written patient education materials were given to her, and she was directed to pertinent websites. Recommendations for withdrawal were made, but if she was unable to finish withdrawing in the hospital, medication-assisted treatment with Suboxone was recommended. The patient decided to stop opioid therapy, and she was discharged 2 days later.
Opioid use disorder is defined by the DSM-5 by specific criteria occurring within a 12-month period. It's a problematic pattern of opioid use which leads to clinically significant impairment. You need at least 2 of the following. So criteria include taking more than is prescribed, persistent desire, spending a great deal of time obtaining the medication, craving, missing obligations at work or home, giving up social activities, taking opioids despite the danger and despite the knowledge that they are causing harm, and having associated tolerance or withdrawal. There are multiple screening tools for substance use disorder. The one we're going to talk about is the SBRT. The SBRT is the Screening, Brief Intervention, and Referral to Treatment tool. This is a step-by-step guide for clinicians. It's intended for outpatient providers to screen a large number of patients, and most patients test negative. About 15% of them will need to get advanced to the second level of screening. So this includes screening and then the brief intervention, which provides feedback to the patient about unhealthy substance use. It also focuses on education, increasing the patient's insight and awareness about the risk related to unhealthy substance use, and enhances motivation towards healthy behavioral change. And the RT stands for referral to treatment. There is a SBIRT toolkit that you can find online, and it contains a rationale for routine screening and has some approaches to screening, and has a script which gives you suggested brief intervention routine. And there's a guide on helping patients who drink too much, a clinician's guide. So why do we screen patients? Because alcohol and drug use are common causes of preventable morbidity and mortality. They prevent things like trauma and injury, criminal justice involvement, adverse mental health, and absenteeism. Because these entities go unrecognized, and they complicate the management of chronic illness such as diabetes and heart failure. And they decrease the frequency and severity of drug and alcohol use. And it's been shown that screening helps prevent further progression of drug-related behaviors. Screening decreases emergency department visits and days in the hospital, and it demonstrates a cost savings to the healthcare system. This is a pyramid graph that shows most people are at low risk of getting addiction, but it is the higher risk patients who go on to have more medical and psychiatric problems. There is an opportunity for prevention if we determine who these higher risk patients are early on and refer them to proper psychosocial care.
Lastly, we worked on developing or actually applied for a $2 million grant. This is an NIH grant for something that we're calling a safe pain management program for primary care. And I'll tell you more about that later. So we see our obligations to be to engage in responsible evidence-based prescribing and to perform risk assessments in everyone, because not all patients have the same risk. And we need to know what our patients are taking. We need to monitor patients on long-term opioid treatment. And we need to do physician and provider education and to give physicians feedback about their prescribing habits. And of course, to start patient education programs.
In order to screen patients for substance use disorder, we need to keep certain protocols in place. We need to maintain a medical treatment agreement and have regular office visits, periodically do urine drug screening, periodically check the P&P and review it. We need to perform pill counts to make sure that they are taking what they should be taking and not taking too much. And we need to consult with their family and caretakers in order to discern what their home life is like. Now that a protocol has been established with the patients, a boundary needs to be enforced. You need to observe and document their behavioral disturbances and then make recommendations which are in the patient's best interest. So you already have a contract in place before prescribing for chronic pain. Then you need to observe their behaviors and document aberrant behaviors across multiple settings in the healthcare system, whether they're in the clinic, the hospital, a physical therapy program, wherever they may be. And we need to discuss concerns with the patient if we have any. If things continue to escalate, we need to recommend weaning and cessation, alternative therapies for pain. We can recommend psychological support and counseling. We can offer referral to addiction services, or we can actually start the medication-assisted therapy. We can give them a letter of opioid discontinuation and can wean the patient until that we should keep them in our care until we wean the patient completely or until there is a proper transfer of care. And then, of course, flag the chart so we can alert each other and future providers on the potential harm to this patient. Ochsner has 2 letters that can be given to patients for non-adherence. The first one is a letter that states opioids will no longer be prescribed. It states that the MD has decided to wean and discontinue the opioid medication and that Ochsner wants to take care of all of the patient's healthcare needs. It lists opioid and pain-related services on the letter, and it has a phone number for addiction services. The second letter is a seek care elsewhere letter. In order to remove a patient from your practice, you need to go through an approval process and would approach your immediate supervisor. Urine drug testing is done to rule out substance use disorder, to confirm adherence, to screen for diversion, to identify substances in overdose situations, and it's used by employers to screen for illicit drug use. Most urine drug screens test for amphetamines, cocaine, marijuana, opioids, phencyclidine, and benzodiazepines. Not included are some of the most commonly diverted medications, like oxycodone, fentanyl, methadone, and tramadol. Systems can add these to routine drug screening if they wanted. Remember that results of urine drug screenings are based off of cutoff points, which depend on the clinical setting. So higher cutoff points are used in employment settings to reduce the number of false positives, whereas lower cutoff points may be needed to screen for adherence to a medication. And lower cutoff points are also needed for children and infants. So you can call the lab and ask them to change it for your purpose. Here are some drug detection times. This means how long do drugs stay in a patient's system. So for alcohol, we know it's about 7 to 12 hours. Amphetamines, about 2 days. Barbiturates can be anywhere from 24 hours to 3 weeks, depending on whether or not they're long-acting. The same is true for benzodiazepines. Short-acting can be as low as 3 days, but it can go as high as 30 days in the long-acting formulations. Cocaine will last 2 to 4 days in your system, and marijuana 3 days to greater than 30 days. So short-term use of marijuana may be only transient in the blood, whereas if they use it every day, it builds up in the fat cells of the body, and your drug test can stay positive for a very long time. Opioids stay in your system 2 to 4 days, methadone about 3 days, phencyclidine about 8 days, and synthetic cannabinoids can be about 72 hours. You need to be aware that patients know how to alter their urine drug screen or to dilute their urine. So these are some methods to screen for adulteration. You can measure the urine temperature within the first 4 minutes after they give you the sample. It should be between 90 and 100 degrees Fahrenheit. And a morning sample can contain more drug. The urine pH can be checked. The specific gravity can be checked. Creatinine concentration can be checked. People add all sorts of things to their urine samples, so be on the lookout for strange results. And if you suspect that a person might be altering their urine drug screen in any way, just collect another sample under direct supervision. Most urine drug screens test for amphetamines, cocaine, marijuana, opioids, phencyclidine, and benzodiazepines. Not included are some of the most commonly diverted medications, like oxycodone, fentanyl, methadone, and tramadol. Systems can add these to routine drug screening if they wanted. There are 3 classifications for opioids. Those drugs that come from opium, which is codeine, morphine, and semi-synthetic opioids like buprenorphine, heroin, hydrocodone, hydromorphone, oxycodone, oxymorphone, and then synthetic opioids, which is fentanyl, methadone, and tramadol. Here's some information about cannabinoids. Cannabinoids come from a plant. It has 460 active chemicals in it. 60 of them are cannabinoids. Cannabinoids may be approved by state governments, but they have not been approved by federal systems yet. They're not approved at most workplaces or the criminal justice system, and schools may still require a negative test. You can have accidental ingestion, which is occurring more commonly with the legalization of marijuana in the last few years. And they are highly lipophilic, and so they do accumulate in fatty tissues. There are some drugs that can cross-react and interfere with the detection, like PPIs, nonsteroidals, and efavirenz. And baby wash products also can cause false positives. So if you happen to be in a room with somebody who's smoking marijuana, you will not get a positive drug screen. Secondhand exposure does not elicit a positive drug screen. Urine drug screens are used to check for benzodiazepine adherence in the clinical setting. Long-acting can be detected greater than 30 days, but short-acting is usually less than a day. And flunitrazepam is the date rape drug. It's available in Europe, so it can come across the pond to us fairly easily. There are plenty false negatives and false positives for benzodiazepines. The urine drug screen will not pick up some of the commonly prescribed medications like Ativan, Klonopin, or Xanax. And other drugs can affect the screen, like sertraline or oxyprozin or efavirenz. Amphetamines like Adderall are commonly diverted, especially among college students. There are drug interactions that can lead to false positives. like over-the-counter sinus medications, bupropion, labetalol, Zantac, metformin, or even Vicks vapor rub and weight loss medications can do it. Cocaine is picked up on the urine drug screen. It's important to remember that just touching it on the surface can lead to a positive result, even if they don't inject it or administer it in any other way. There's this common belief that there's some false positives with some drugs, but this is not true. There are no false positives with amoxicillin or with any of the other benzocaine, lidocaine, procaine, or tetracaine drugs. The urine drug screen will detect PCP or phenylcyclidine. This is commonly known as angel dust. It is used by people for its mind-altering effects. It can cause hallucinations and distorted perception of sounds. In modern times, it's being used by dipping marijuana cigarettes with it, and they're calling it all these crazy names like rocket fuel, embalming fluid, smoking wet, illy, or fry. And it's associated with violent and aggressive behavior and severe paranoia. The intoxication can last 4 to 6 hours. Detection time is about 8 hours. You can get false positives with tramadol, dexamorphin, Benadryl, ketamine, Effexor, or lamotrigine. Also, you can get false positives with bath salts. So designer drugs are made by people in order to avoid detection from urine drug screens. So these are psychoactive substances, or they're used for performance enhancing. Some were a byproduct of research labs, and then they were co-opted later for recreational use. There's no clinical trials. So this includes a broad array of different compounds, like tryptamines, anabolic steroids, psychedelics, dissociative, piperazines, empathogens, stimulants, sedatives, androgens, peptides, PDE5 inhibitors, nootropics, and canthiones, and even herbal remedies.
Patients actually, they're happier, they're not constipated, they're not grouchy as much, they are participating in their care quicker, they're getting up quicker, and I do believe they're leaving the hospital and going to rehab, and they're using less opioids when they leave. So we need to do more in looking at how we treat pain in the preoperative and perioperative periods. Now, the Safe Pain Management Program, this is a program that is designed for primary care. It is a $2 million NIH grant proposal that was submitted by Dr. Ebony Price Haywood. And it's modeled off of the Coumadin Clinic. Now, the idea of this program is to help primary care physicians with patients who are having that difficulty in that very first transition, that transition from acute pain to chronic pain. If they're having difficulty getting a patient off of opioids, they will be able to send that patient here. And it will be managed by advanced practice practitioners and pharmacists. And those professionals will help wean the patients from their opioids, start non-opioid therapies, start the psychosocial care and the biopsychosocial model, and refer those patients to that multi-model approach, by figuring out what their needs are. So we're still waiting to get this grant. We are in the competition. We're high up in the competition. We're being told that results will be in very shortly. Ochsner is also expanding psychiatry care services. And we've just opened a new psychiatry hospital called River Place Behavioral Health. In there will be a dual diagnosis unit for opioid-related patients who have other psychiatric disorders. Ochsner is also expanding their medication-assisted therapy in the psychiatry clinic and their outpatient programs for substance abuse that were present formerly are also being expanded. Also, we are collating outside resources to refer patients who need psychiatry resources in a web-based program that we call this Ochsner Community Connection, and you can access it through SharePoint. We are developing partnerships with the behavioral health local governing entities, and here they are. We want our patients to have access to these behavioral health units because the federal government is investing a lot of money right now into developing their programs. So we want to help them develop individualized care, one-on-one care programs for offering these patients the proper psychosocial care. What we don't want is programs that just dispense methadone and not pay attention to the patient at all. So we definitely have to work with our local governing entities and the behavioral health units to help them, give them patients that they need to develop their programs and to help them develop their programs. Here are some other treatment programs around town for pain, dependency, and addiction. Some of them are private and some of them are public. All of these we've looked at and we think that they're good programs.
We need to make sure our patients get into medication-assisted programs. And Ochsner has been working on developing means to make this happen. We've created an online web source called Ochsner Community Connection, which is a very broad resource that contains all programs throughout the state. You basically just put in their zip code and they'll all pop up for you. You can find this on OshWeb. And we also have our psychiatry department, a new psychiatry hospital, which has patients, does admit patients with dual diagnoses. And there's a new hospital beds available at the St. Charles Parish Hospital. And we have an opioid stewardship quarterback who can help with this. Her name is Jaleesa Tyndall. Her role is to connect providers to available resources at Ochsner in the community, and she will meet with the patient. Her phone number is 703-1360.
You can give less, of course, but if you do need to give more for any reason, you need to clearly document why you are giving more than 7 days. And then the last bill that passed created an advisory council for heroin and opioid prevention and education. There are other opioid laws that are in the works right now, and we'll see what happens, whether or not they get approved or not. Now we have a collaboration with CVS Pharmacy. Ochsner is collaborating with pharmacists to educate middle and high school students. We've developed opioid-related videos to go into these schools and teach them about the bad effects of opioids. The opioid stewardship team has some goals for 2018, which includes many of things on this slide. In particular, we want to begin looking for non-pharmacological pain modalities and non-opioid related pain modalities, both through our pain management services and our rehabilitation services. We also need to establish routine metrics, and we also are starting a project we're calling Project ECHO, which is a web-based program to teach physicians how to prescribe Suboxone. So we're going to end this segment with a call to action. We all have a role to play in reducing harm and mortality from the opioid epidemic, because the healthcare industry had a role, despite great intentions, in creating the epidemic. Please support the new tools and use the tools to prescribe these dangerous medications responsibly. Always treat patients with chronic pain, opioid dependency, and addiction with compassion, understanding, and the most effective therapies. So this is the end of the first half of the Opioid Stewardship Physician and Provider Education Program for Oxnard Health System. The second half will be a lecture titled Update 2018 and Best Practices for the Prescribing and Managing of Controlled Substances. And we will divide it into three parts: the opioid epidemic in 2018 and the healthcare regulatory bodies and what they're saying about the epidemic, best practices, meaning pain, dependency, and addiction treatment, intentional withdrawal and internal skills for the provider, and then lastly, we'll end with diversion. Welcome back to the Opioid Stewardship Physician and Provider Education Program for Oxnard Health System. The second half of this series will be titled Update 2018 and Best Practices for the Prescribing and Managing of Controlled Substances. We will divide it up into three parts. First part will be about the opioid epidemic in 2018 and the healthcare regulatory bodies and what they're saying about the epidemic. The second part will be about best practices for the prescribing and managing of controlled substances. And the third part will be about learning about understanding diversion. So part one of update and best practices, the opioid epidemic in 2018 and healthcare regulatory bodies. We will understand what is changing in our country. We'll understand the effect of opioids in women, and we will learn what the U.S. government and regulatory bodies are saying about the epidemic. So first, I want to point out this great video, which is great physician education product put out by Baylor, Scott, and White from Texas. It's about 2 hours long. It's very comprehensive. But what's unique about this one is that it has skits at the end of it with real physicians and patient actors that will help you with communication skills. So a lot of what I have to say today kind of mirrors some of the stuff in this video. And I think that, you guys should all take a look at this. And the second thing I want to do before we start is teach you my new mantra for this year, which is no new cases. No new cases. We can treat opioid-dependent patients better. We can monitor them more closely. We can learn how to manage addiction patients with medication-assisted treatment. We can reduce diversion of tablets in the community. But the real solution to this epidemic is no new cases. And that means no new cases of opioid-induced chronic pain and no new cases of opioid dependence. Now here is a slide revealing drug overdoses over time from 2003 to 2014. Overdose is only a small part of the tragedy associated with this epidemic. It does not include the morbidity, the psychiatric illness, the hardship on families, the loss of employment opportunity, the loss of autonomy, and the loss of freedom that comes along with being opioid dependent. Now, as opioid sales increase, so do admissions to the hospital and death rates. And so do increases for admissions to the intensive care unit for neonatal abstinence syndrome. Now this slide shows heroin admissions from 2002 to 2012, affecting mostly the East and West Coasts. But note that California and Illinois do have improving heroin rates, admission rates. Now Louisiana does not have a heroin problem. We still have a prescription problem. Now this slide shows prescription admissions to the hospital. Louisiana has always been a high prescribing state. And this is true even before the CDC started monitoring. Now, the cardinal features of our epidemic are diversion of tablets, addiction, chronic pain, psychiatric illness, and overutilization. These features all reinforce one another. So what is our country, government, and healthcare system saying about the epidemic? Well, all-cause mortality for men age 45 to 54 in the U.S. is rising. It's not in line with the rest of the world. France, Germany, UK, Canada, Australia, and Sweden here on this slide. But if you look at US Hispanics, and that's the dark blue line that's in the middle, they're the most disenfranchised subgroup in our population. This population is not exposed to the US healthcare system. Look at their mortality rate. It's in line with the rest of the world. Last year, the CDC announced that life expectancy went down in the United States for the first time since 2015. And the CDC director, Thomas Frieden, said that the opioid epidemic is a doctor-driven epidemic and that America is awash in opioids. There are 91 opioid overdose deaths per day in 2017. And that means one death every 17 minutes. And there are more overdose deaths than there was breast cancer deaths last year. And opioids are the most frequently prescribed class of drugs prescribed. And the number of patients who abused drugs last year exceeded the number of total cancer patients in the United States. We spend $78.5 billion in economic cost annually. And the highest prescribing states here are in purple. In 2015, Louisiana prescribed more opioids than we had people in our state. So with all the sobering news, I need to repeat my mantra: no new cases. Let's talk about gender differences. Deaths from prescription painkiller overdoses among women have increased more than 400% since 1999, compared to 265% among men. And women are more likely to have chronic pain, they're more likely to be prescribed painkillers, and they're given higher doses for longer periods of time than men. And women have become dependent more quickly than men do. And neonatal abstinence syndrome has increased by 300% between 2000 and 2009. We need to do a better job in screening women for opioid risk, and the opioid risk tool should help. It contains the sensitive question about pre-adolescent sexual abuse, which is critical for women. Now, 1 in 5 women experience some sort of child sexual abuse, and child abuse is a risk factor for the initiation and escalation of substance use among women. And the opioid risk tool is a validated tool in the literature, and it reflects real pathology in the community. Failure to screen places 20% of women at a risk of lifetime of addiction. Now, the National Survey on Drug Use and Health stated in 2010 that 16.2% of pregnant teenagers and 7.4% of pregnant women use illicit drugs. This leads to complications for both the mother and the baby. For the mother, there is increased infections, including MRSA infections, dental disease, seizure disorders, and then poor control of their chronic medical problems. And they also have increased sexually transmitted diseases, all diseases, but especially HIV and hepatitis C. And psychiatric disorders are increased. Women who use drugs, 70% have psychiatric disorders as well. Now for the baby, this means increased obstetrical complications, preterm deliveries, fetal growth restrictions, neonatal abstinence syndrome, there's increase in sudden infant death syndrome, and then there's the long-term sequelae, like poor nutrition, neglect, abuse, mental delays, and developmental delays. Risk of overdose in children whose mothers have been prescribed opioids increases 2.5 times. So we need to be careful about diversion of tablets and prevent it. So again, let me repeat that mantra: no new cases. No new cases of accidental overdose, no new cases of opioid-induced chronic pain, and no new cases of addiction. So what about the pharmaceutical industry? Purdue Pharma announced it will stop promoting opioids to doctors. It cut its sales force in half. The company now routinely directs doctors to the 2016 CDC guidelines. The DEA has expressed concern of the company's marketing of OxyContin, and in 2007, it paid $634.5 million in criminal and civil fines for misleading advertising. So what is the U.S. government and the regulatory bodies saying? President Obama passed the Affordable Care Act and the Substance Abuse and Mental Health Parity Act. Both of these have provisions for mandating treatment and payment for addiction and mental health disorders. And President Trump, in October of 2017, declared the opioid epidemic to be a national public health emergency. The FDA placed a black box warning for opioids and benzodiazepines in 2017. And the CDC has always been the go-to site for the latest information about the epidemic. Here's a link for a document that will teach you more about treating chronic pain without opioids. It's very good. And you should download the 2016 CDC chronic pain guidelines and get familiar with that. Now, the Federation of State Medical Boards, this is the same group that told us in the 1990s that we would not be sanctioned or disciplined if we prescribed opioids. Well, in April of 2017, they published a new policy for the use of opioid analgesics in the treatment of chronic pain. It's an excellent review of chronic pain management and easy to find online. The Joint Commission implemented new standards for January 2018. All hospitals are required to have an opioid stewardship team. They want safe opioid prescribing identified as an organizational priority for the hospital. They want us to identify high-risk patients and to monitor high-risk patients. Hospitals must facilitate clinician access to the PMP, and the hospital needs to provide non-pharmacologic pain treatment. The hospital needs to educate the patient and the family on discharge, and the hospital needs to minimize risk associated with treatment. The hospital also needs to develop a pain treatment plan based on evidence-based practices, the patient's clinical condition, the past medical history, and the pain management goals. And these goals need to be realistic expectations and measurable. The Joint Commission also says that the hospital needs to reassess the patient's response to treatment. That means document the response, document the progress towards goals, and this time they included functional status, and they recognize that functional status is important to monitor chronic pain. They also say that we need to document side effects and document risk factors for adverse events. The Joint Commission is stating that the hospital must provide staff and licensed independent practitioners with resources and programs to improve pain assessment and management and the safe use of opioids. The hospital also needs to provide information to staff on available resources for referral of patients who have complex pain management needs. The hospital must engage in organizational performance improvement activities to improve the quality of care and treatment and services. And the hospital must conduct performance review activities on pain assessment and management, and that means collect data to identify areas that need change. Well, you remember that fifth vital sign. The Joint Commission is now recognizing that functional status needs to be measured to monitor chronic pain. This was a subjective pain scale. It was not a true vital sign. It is not objective like other vital signs. It may assist in the treatment of acute post-surgical pain, but it's not adaptable to patients who are on chronic narcotic therapy. And in initial studies, it was used and developed as a screening tool to evaluate if further questioning and a more thorough pain evaluation was warranted. It was never meant to be an accurate measure of pain and was not meant to be attached to a dilaudid sliding scale. What is HIPAA saying about the opioid crisis? Well, they came out with this new policy. It's only 2 pages long and easy to download. It allows professionals to share health information with loved ones in emergency and in dangerous situations. And it gives providers broad ability to share that information in a crisis without the patient's permission. And we may use professional judgment, of course. And we may disclose information to family and close friends who are involved with the care of the patient. The information must be directly related to the family or friends' involvement with the care. And the patient must be incapacitated or unconscious. We can still inform patients or family members as well who are in the position to prevent or lessen a serious and imminent threat to a patient's health and safety. And they specifically state such as continuing opioid abuse. So to review capacity, you need to ask this question. Does the patient have the ability to understand relevant information? Can they appreciate the situation? Can they reason and manipulate information rationally? Can they communicate their choice effectively? If they can do all those things, then they have capacity. But capacity can change with the clinical situation. It's temporary. And in the hospital, they usually come in, the patients with opioid-related problems, they usually come in lacking capacity at the beginning of their admission, and they gradually gain it by the time they leave. So we still need to respect capacity if there's no imminent threat to health or safety. So remember to document that continued use of opioids is a serious threat to health and safety. And document that you told the patient that, and that you told the family member that. In summary, HIPAA wants us to put safety over privacy, and that's very reassuring. What about press gaining? The Hospital Consumer Assessment of Healthcare Providers and Systems changed their survey questions about pain during the hospital stay, effective January 1st, 2018. There are 3 new questions about pain communication, and they will replace the previous questions about pain management. And the Centers for Medicare and Medicaid Services removed the survey's pain management measures from the hospital value-based purchasing program. Now, the 2018 survey will have these questions. There's 3 questions. During this hospital stay, did you have any pain? Yes or no? During this hospital stay, how often did the hospital staff talk to you about how much pain you had? Answer can be never, sometimes, usually, and always. And the last question, during this hospital stay, how often did the hospital staff talk with you about how to treat your pain? Never, sometimes, usually, and always. Here is a slide of Ochsner ED doctors comparing their prescribing patterns and their press gaining scores. The higher prescribers are on the right side. As you can see, there's no correlation. High prescribers did not get high scores. But doctors still feel uncomfortable about press gaining. Greater than 50% of doctors believe that patient surveys did influence them to prescribe more opioids. And it's uncomfortable that metrics were based on patient experience, not on the patient's health outcome. And these surveys are administrative tools that are used to change physician behavior. It is a metric used for hiring, firing, raises, promotions, demotions, and many other career decisions. Now, the Annals of Emergency Medicine in October of 2013 produced an article that also demonstrated that there was a lack of association between press gaining satisfaction scores and analgesic administration in the ED. So the question remains, did the use of press gaining affect physician prescribing, And that question is not answered. Now, there are 3 new Louisiana laws and more coming up the pipe. The first law requires that we access the prescription monitoring program every 90 days on a patient who's on long-term opioid therapy, and that the Louisiana State Board of Pharmacy ought to enroll prescribers when they come up for license renewal. And it requires that we have 3 hours of opioid-related continuing education prior to license renewal. And the second law limits opioid prescriptions to 7 days for the patient's first prescription. It doesn't mean that you have to give 7 days, but it limits it to that amount. And the last bill creates an advisory council on heroin and opioid prevention and education. The Louisiana Board of Pharmacy is making it easier to access the prescription monitoring program. You no longer need a notary for that process, and we have it so that if you click on an EPIC right above the P&P, you can get directly to the form that you need to fill out in order to get that done. So now that our federal and our state governments and regulatory bodies are getting their values straight about opioids, we need to repeat that mantra: no new cases. So this concludes our first part of our second half of the Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. Next will be part 2 of Update 2018 and Best Practices for Prescribing Controlled Substances, which will be about understanding the treatment of acute pain, chronic pain, and addiction, to be introduced to medication-assisted therapy, and we're going to learn about intentional withdrawal and provider internal skills. Thank you. Welcome back to the Opioid Stewardship Physician and Provider Education Program for Ochsner Health System. This will be part 2 of Update 2018 and Best Practices for Prescribing Controlled Substances. This will be about understanding the treatment of acute pain, chronic pain, and addiction. We will be introduced to medication-assisted therapy, and we'll learn about intentional withdrawal and provider internal skills. Let's start with talking about opioid prescribing and internal medicine and primary care. Primary care physicians were taught to treat pain with opioids between 1990 and 2016. There was no differentiation between acute pain and chronic pain in many of these lectures. Opioid dependency and addiction was left untreated with limited resources, and primary care physicians and hospitalists felt the brunt of the patient's unmet psychosocial and psychiatric needs. Here is the care pathway for the prevention of addiction that we went over previously. Understand that this is one disease process which is progressive, and it represents that changes in brain anatomy and function are taking place. There is a rough timeline here, and remember that addicted patients usually have an underlying psychiatric disorder, and it's that psychiatric disorder which is driving that movement from acute pain towards addiction. Risk assessment includes checking the opioid risk tool score, checking the prescription monitoring program, the urine drug screen, the morphine equivalent daily dose, and the patient's psych history, opioid history, and pain history. And if they have aberrant behaviors, that means their prefrontal cortex is likely affected, and they have poor judgment and lack of impulse control and difficulty learning. If they have side effects or late effects, then you need to stop their opioids. Remember to make the diagnosis to help your system and the insurance companies and the government monitor these patients and provide resources for them. So we'll start with the best practices for prescribing controlled substances, starting with acute pain. Most acute pain can be managed without medication. You can use rest, ice, and compression. Now, deep breathing is the #1 pain reliever in the world. That's why we use it with childbirth. It really works. It distracts the patient, it calms them down, it gives the body and mind time to process the trauma. It does not reinforce the pleasure signal at the same time as the painful experience. I've been using it in the hospital for wound care and other things. It does work. Elevation, joint and trigger point injections, acupuncture and dry needling, massage, TENS units, physical therapy, exercise therapy, cognitive behavioral therapy, sleep hygiene, all these things can be used to treat acute pain. If you need medication, acetaminophen, non-steroidal anti-inflammatory drugs, COX-2 inhibitors, anticonvulsants, tricyclic antidepressants, topicals like capsaicin or lidocaine patches. I wanted to say something about Tylenol. Higher doses of Tylenol, approximately 1,000 milligrams, will hit the cannabinoid receptors as well as the Tylenol receptors. So you're getting a whole different mechanism of action and a whole different mechanism for analgesia. So you just need to make sure that they don't have liver disease before you start giving them higher doses, and you need to make sure that they're not drinking alcohol actively. The National Safety Council looked at Tylenol 500 milligrams plus ibuprofen 200 milligrams, and they compared it against oxycodone 15 milligrams, oxycodone 10 plus 500 of Tylenol, and then naproxen 500 milligrams. And what they found was in post-operative pain patients that the numbers needed to treat were actually lowest in the non-opioid group, that is the Tylenol and the ibuprofen combination. This had already been demonstrated in some European studies. So they actually were able to demonstrate here in the United States that you can get better analgesia with the non-opioid drugs. Now, in acute pain, sometimes short-term use of opioids, may be appropriate. But remember that pain is the body's form of self-protection. It's a transient thing in routine circumstances. So we need short prescriptions, and we need good physician judgment. The CDC guidelines recommend 2 to 3 days of therapy. We need to discuss the risk and the reasons for not prescribing. And we need to explain that some pain is to be expected. We're not going to eliminate all pain. And we need to do that risk assessment, of course. We need to understand who our patients are and what their risk is. We need to know what our patients are taking. And we need to see if they are adherent, they're telling us the truth, and screen them for substance use disorder. Now, chronic pain has both emotional and sensational components to it. Opioids are not effective and could potentiate chronic pain. If a patient has chronic pain, it means that changes in the nervous system are occurring and neuroplasticity is developing. Emotional triggers take a greater importance in the pain response. And the pain pathways change both centrally and peripherally. So you get things like wind-up, which is increased pain sensitivity, and allodynia, which is pain to light touch, and hyperalgesia, especially opioid-induced hyperalgesia, and central sensitization. So remember, in chronic pain, if you reduce the emotionality, then you also can reduce the pain. You need a comprehensive biopsychosocial approach. So patient education about the neuropathophysiology of chronic pain, it actually works. Now, chronic pain treatment. You need to focus on function, not pain scales. Use long-acting, once-a-day medications, preferably non-opioid medications, instead of PRN medications, in order to take the focus off of their condition. Get the patient involved with a pleasurable activity. They'll need reassurance and positive reinforcement. And also they'll need cognitive behavioral therapies, which you can start right away, but you also need to find a mental health care professional who can help you because this is very time consuming. Patient will need to learn how to reduce negative thinking, will need to learn how to understand their condition, learn how to change their thinking pattern to stop that reactive, repetitive thinking that happens. Also, they can be trained in mindfulness meditation. And if they do all these things, it will not only help their pain, but it will help them with any past trauma that they may have had, or with anxiety or with depression. For chronic pain treatment, the goal is to improve their functional status. You can use Tylenol and nonsteroidals, topicals, and patches. Don't forget to treat the central sensitization with anticonvulsants or tricyclic antidepressants or SNRIs. And you could use muscle relaxers temporarily. Make sure you fix the underlying problem. If there's a biomechanical problem, a joint problem, make sure you get them referred to the proper place, get that taken care of. If they have emotional problems in the home, that needs to be dealt with properly. And always work on their sleep disturbances. Screen them for obstructive sleep apnea. Exercise is very important in chronic pain treatment because exercise affects the musculoskeletal system, the cardiovascular system, and the brain. And for the musculoskeletal system, what it does is it helps prevent further declines on the pain cycle, which is a negative feedback loop of immobility followed by more pain, followed by more immobility, followed by more pain. With therapy programs and with just taking baby steps, you can actually reverse that process and get them into more higher levels of activity. And also, exercise improves the cardiovascular system, which will improve their endurance. And exercise affects the brain in many ways. One particular way is that aerobic exercise actually increases a hormone called brain nerve growth factor. And brain nerve growth factor actually circulates in the blood, and it actually stimulates the growth of dendrites in the brain. So exercise is very important for these reasons. And also you need to address barriers to treatment. If the patient is having problems, make sure you address those and try to get it under control. Now, if you have to use opioids with chronic pain, make sure you establish the goals of care and what the functional goals are going to be, and discuss an exit strategy at the onset. You need to discuss the risks and benefits and the harms of opioids, and you need to have that controlled substance agreement or the pain contract. You need to do a full risk assessment before starting with the psych, opioid, and pain histories, and check their PMP and opioid risk tool score and urine drug screen. And if you have them on opioids, avoid benzodiazepines. Make sure they avoid alcohol, soma, antihistamines while they take the opioids. Higher doses of opioids have higher fatalities. Follow them every 3 months at least, and make sure you get that prescription monitoring program checked every 3 months as required by law. Now, be aware of opioid-induced hyperalgesia. This occurs when opioids actually make pain worse. Patients have heightened sensitivity to nociceptive stimuli, and escalating opioids actually fails, and tapering or stopping the opioid actually improves the pain. And this is something that we actually see a lot of in the hospital. I actually had a patient transferred from Mississippi because she had gallbladder surgery, and her syndrome, her pain syndrome and abdominal pain just got worse and worse after surgery. By the time she got here, she couldn't even handle having an IV placed. And she actually yelled at her mother, "You do not understand my pain." So anyway, we stopped her opioids, put her on the medicine for central sensitization, and her pain drastically improved the next day. And she was able to go home 2 days later. So this is something we do see. And so be aware of it. And if you notice that it's happening, stop the opioid. Now let's talk about opioid dependence. Opioid dependence can begin as soon as 5 weeks after starting opioids. It's both physical dependence and mental dependence. It's associated with withdrawal symptoms and tolerance. So if this happens, these patients need to be weaned because they're moving along that pathway towards addiction. Withdrawal symptoms, can last about 3 months after cessation. Now, weaning, which we're going to talk about in greater depth later, but for now, slow tapers have less discomfort than rapid tapers. And remember, there's going to be increased pain perception every time you lower the dose. And that increased pain perception will last about 3 to 4 days. So teach your patients to expect this so that they will be aware of it. And make sure you give them reassurance that it's not their pain syndrome or their back problem getting worse or their arthritic problem getting worse. It's just a reflection of cutting back on the opioid dose. And if you're having problems, you can always slow down the taper. Especially, this is important in the outpatient setting, especially. Use alternatives when you're trying to wean patients. Treat that central sensitization. Start the cognitive behavioral therapy and the psychosocial support. These patients will definitely need a lot of reassurance that their physical condition is unchanged. Now, benzodiazepines need to be tapered due to the risk of seizures, especially if they're on both. Now, there's no set rule about which one to taper first, but I'll tell you what I like to do. I like to wean the benzodiazepine first because of the risk of seizures. To minimize seizures, it makes sense to get rid of that one first, because if you take away the opioid first, then the patient may act out or take their other meds more frequently, and then mid-month run out of them and then have a seizure. So we do have patients that present with seizures in the hospital all the time. For this reason, so for that reason, I would prefer to stop the benzodiazepine first and then the opioid. Now, when should you stop opioids? When should you recommend a taper? Well, if the pain gets worse after starting, then you should stop the opioid. If tolerance develops, if the controlled substance agreement is broken, then you should stop or wean. If there's evidence of substance use disorder or misuse, for example, if a urine drug screen turns positive for cocaine or marijuana, you need to stop the opioid. If the behavior is uncontrolled, that means that they're losing prefrontal lobe function. And if they have complications of opioids, well then it needs to be stopped. When should you refer a patient to interventional pain management? Well, you should refer them if they're failing treatment, if they have functional limitation, if you're looking for options other than surgery. And if you need a more comprehensive pain evaluation, they can do it there. Many pain management centers or interventional pain management centers will offer multidisciplinary approach and will offer physical therapies and pain psychologists. They'll do the cognitive behavioral therapies, but they mainly focus on procedures, trigger point injections, nerve blocks, joint injections, epidural steroid injections, and spinal cord stimulators. They don't usually taper opioids, and they don't treat substance use disorder. Now, if the patient fails interventional pain management, that patient will be referred back to the primary care physician. And the primary care doctor will have to decide on what to do next, either to refer that patient for a surgical intervention, or maybe that patient needs an addiction psychiatry evaluation, or long-term maintenance, or medication-assisted therapy. Or maybe the primary care physician needs to keep that patient stable in the clinic and give medication-assisted treatment, to the patient. Or maybe that this is a palliative care case, that we need to just maintain the patient on their opioid therapy and progress them towards hospice care. Now, another option for chronic pain is functional restoration. Functional restoration programs these are centers that accept a broad range of patients. Usually they have chronic pain and opioid dependence. These are outpatient programs. They're usually 4 to 5 days per week, and they last 3 to 4 weeks. They provide an array of activities like therapy, group therapies, and cognitive behavioral therapies. They're goal-centered and patient-oriented. The patient must be an active participant, and they must play a central role in regaining their quality of life. These functional restoration programs need well-defined outcomes to measure their progress, and they have been proven to reduce opioids and to improve function. And if you don't have access to a functional restoration program, well, you can build a collaborative model if you work with your rehab team, your physical medicine and rehab team, and with your local psychiatrist or psychologist. You can actually build a functional restoration program between the 3 specialties. Now let's talk about addiction. Addiction is continuing to take opioids despite the harm. It's a neuropathology of the motivational reward system, and usually there's an underlying psychiatric illness. It is dependence and tolerance plus these other factors: craving, persistent desire, time spent obtaining the opioid, failure to fulfill roles at home or work, giving up the social and occupational responsibilities in order to take their opioid. Now, treatment of addiction, you need to address the psychosocial problems. And only 10% of opioid-dependent patients are actually being treated. So we do have a lot of room for improvement to get these patients into the right level of care. You need to remove the environmental cues and treat these patients with alternatives and consider medication-assisted therapy like methadone or Suboxone. Now, primary care doctors who have a large opioid-dependent and addicted patient population should consider taking the 8-hour course to learn how to prescribe Suboxone. And this is to keep these patients stable in the healthcare system and to give them a drug that is safer and less likely to result in problems and diversion. Now, medication-assisted treatment could be methadone, in which you need a behavioral health clinic to dispense it if the patient has an addictive disorder or has substance use disorder. Or you could use Suboxone, which was approved in 2003. And primary care and internal medicine providers can use Suboxone if they get certified. Outpatient providers and inpatient providers need to develop relationships with the local medication-assisted therapy programs in our area. And this is to take advantage of all the federal funding that is coming down to these programs. We want our patients to have the benefit of that federal funding. We want to look for programs that offer individualized attention and care and programs that address the psychosocial needs. Now, Suboxone is a drug that contains long-acting opioid, which is buprenorphine, and naloxone, which is the antidote for opioids. It's an agonist-antagonist combination. Suboxone has a lower overdose rate. It has less risk of abuse, less risk of diversion, less addictive behaviors, and the most important thing is that it helps retain patient in treatment programs. When you prescribe Suboxone, they then have improved behavioral control, and that allows them to address all those psychosocial factors. Suboxone blocks the effects of other opioids, and it is covered by Medicaid. Suboxone was traditionally used for heroin addicts, but now it's also being used for prescription addicts. Now, other benefits to Suboxone, again, it's the partial opioid agonist. It has milder effects. It fills all the brain's receptors. It fills the brain's receptors, opioid receptors, without causing that much of a high. And so it is much more difficult to abuse. And the added naloxone will block other opioids from the brain's receptors. So the other opioids in the community are not effective. They don't cause the high. These can be prescribed from a doctor's office, Suboxone. And in studies of opioid discontinuation programs versus opioid replacement programs, it was shown that the replacement group had better adherence and better outcomes. Now, Suboxone dangers, it is long-term. It can produce dependence in users. You need long-term tapers under medical supervision. So you need an MD. You need to have a comprehensive treatment program. They absolutely have to have that psychosocial care, or they'll never be able to wean off of their Suboxone. If not used properly, it can lead to withdrawal symptoms. And it comes in a sublingual film. If they inject it, it can lead to death. And other fatalities can occur when it's used with benzodiazepines or with alcohol. So that needs to be avoided. Now here is a link to the provider's clinical support system, which has the 8-hour course for getting your X license and to get the DEA waiver training for medication-assisted therapy. This will allow you to prescribe buprenorphine and treat substance use disorder. It's free, and they have live courses, they have a webinar, and they have online events. It's for practicing physicians, it's for residents, it's for nurse practitioners, and for physician assistants. And there are residency training programs available through this. And I also want to talk about naloxone. Naloxone is the antidote. And what I mean by that is it halts respiratory depression. If a patient overdoses, it can be given in the home or in the outpatient setting, and the patient will wake up, out there, and the family will need to call 911 or bring them to the hospital right away. Now you need to give them 2 doses because it is very short acting. And if they're driving on the way to the hospital, the patient could easily fall back into respiratory suppression. So the second dose might be needed. It comes in a nasal spray or an IM injection. And families need to be instructed on how to use naloxone. Our pharmacists are learning how to teach naloxone administration to families as well. Now, we need to give naloxone to all patients who have a morphine equivalent daily dose greater than 90, to all patients who have substance use disorder, to all patients who take both benzodiazepines and opioids, and to all patients who undergo withdrawal. And that means if they undergo withdrawal in the hospital setting, or if they just quit taking their opioid at home on their own, or if they go through opioid withdrawal in the clinic setting. This is because once a patient stops taking their opioids, they lose their tolerance. It takes about 2 weeks to lose tolerance to opioids. And if they relapse a month or 2 months later and they go back to their old dose, it might be way too much for them, and that would put them into respiratory suppression. And this is how a lot of our movie stars have passed. So make sure you prescribe naloxone to our patients. So with all this information about the treatment of opioid dependence and addiction, let's repeat that mantra. No new cases. No new cases of opioid-induced chronic pain, no new cases of opioid dependence, and no new cases of addiction. Okay. Now we're going to talk about intentional withdrawal. And what I mean by this is that you have identified a patient who is opioid dependent and is having complications, or a patient with chronic pain, and you've decided that the opioids are harming the patient more than helping. And now you need to put that patient through an intentional period of withdrawal. Often this happens in the hospital when the patients are admitted because they're having complications. And we need to address the physical, psychological, and social aspects of opioid dependence. Now, for withdrawal, education is key. And Aksha now has 6 patient education handouts to assist in this process. And you can access them on Cranes. First one we have developed is safe use and side effects of opioids. And I like that one because we have a picture of the brain in it. It's a pamphlet. And you can actually draw the brain, the pain pathways. It has the brain disease model of addiction already there. And it really helps to engage the patient and talk about how opioids work in the brain. And that's been proven to be effective, and I use it all the time. It does work. And once the patient understands what's happening in their brain, the majority of them want to stop or get off the opioid therapy. Now, there's also opioid medication guide for patients. This one is for admission. It will be included in their admission packet. And we have managing your opioids at home. Patients will go home with this if they're prescribed an opioid. It will be attached to the ABS at discharge. There's one called Important Facts when taking opioid medication. This one is a little shorter, will be ideal for the clinic setting. And then there's another one on understanding chronic pain. You need to go over that more with the patient, and understanding opioid dependency. And we're still working on one which will be understanding substance use disorder and addiction. And that will be added hopefully by the end of the year. It will contain HIPAA language for addressing families who need to manage their loved one at home. And it will also recommend a treatment plan for that particular patient. And it can be given to the patient or can be given to families if the patient is incapacitated. Now, in the hospital setting, this intentional withdrawal section is really intended for providers who work in the hospital. But some of the same concepts can be used in the clinic as well. But a lot of these patients are already having problems related to their opioids when they come in. First thing you want to do is establish a good relationship with the patient. And it really is best if you have buy-in from the family and family support. And this is common to get family support, actually, especially in our elderly population. You want to document their behavior and their reasons for withdrawal, and for the reasons for the withdrawal recommendation, ahead of time. You need to be observing their behavior, documenting their behavior, as you're doing your medical surgical evaluation, just in case the situation develops later, then you have established a pattern of behavior. And you want to look for patterns of behavior. Look in the previous medical record to see what else has happened in the patient's history. You want to complete that medical and surgical evaluation. This is really important because you need to understand that addicted patients also get real medical and surgical problems. And it can all be very complicated and confusing. So make sure you complete and do all the testing that needs to be done to finish that evaluation before you start to withdraw a patient. Then you make a plan and you discuss it with the patient, and you discuss it with the nurses and the caretakers and the family if they're available, and you discuss with the patient what the physical symptoms are going to be so that they'll know what to expect. Tell the patient that they may have increased pain sensation throughout the process, and that this sensation does not signify that there's more pathology. I like to use the analogy of putting your hand in cold water, and then when you take it out, your hand feels hot. It's the same mechanism. The brain is adapting to change. Only with opioid withdrawal, it takes 3 to 5 days to get that adaptation to complete. You need to monitor your patients for new problems, of course, throughout their stay, and treat chronic pain and hyperalgesia with alternatives and with non-opioid therapies. And add treatment for that opioid-induced central sensitization, the anti-seizure med, the tricyclic antidepressant, and SNRI. And start to treat their psychosocial care in the hospital. Give them reassurance and praise daily at the minimum, and address their barriers if you can, and address family issues if you can. Start teaching and doing cognitive behavioral therapy. You can teach serial relaxation. You can teach them how to reduce their negative thoughts. You can teach them how to focus on something else and take advantage of what they already do, like prayer or writing. One time I had the patient make up a mantra, and she repeated it every time she had increased pain perception, and it worked beautifully. You can use music. You can use visits by the family. I've asked family members to stagger their visits so that they come at multiple times as a method of distraction. And there are other methods of distraction. Sometimes I'll just tell the patient to get out of bed and then walk them down the hall, and we talk. That has a great benefit to the patient. Also, teaching the patient how opioids work in the brain. This is really important. You can recruit family and social support. Make sure you do that before discharge, and also physical therapy and occupational therapy. They can help with distraction and with monitoring their functional status, as well as helping improve their physical limitations. Now, you want to monitor functional status when you're withdrawing patients. Also, you want to monitor the number of aberrant behaviors and record the aberrant behaviors whenever they occur. And evaluate capacity and document it daily. This is just in case the patient decides that they want to leave. You've documented and done your due diligence to make sure that they have the capability of making that decision. Ongoing management of the patient's painful condition is really important. Make sure that they're getting their wound care, or they're doing whatever they need to be doing to get better. And one of the most important things is never abandon the patient in pain. There's a lot of reasons for this, but you don't want to send someone out if they're actively in pain or if they're having active behavioral problems. Now, if they're not adherent or if they refuse your care, well, and they have capacity, well, that's a different story. In that case, you need to maintain your plan, be strong, and give them the good advice that you would give any patient in that situation, and let them abandon you. Help them transition to another caregiver if they like that. Tell the patient that if they fail weaning, that you're going to refer them to medication-assisted therapy for long-term maintenance. You can use clonidine, which helps with sweats and anxiety if their blood pressure will allow. But a lot of these patients are having diarrhea in the hospital, and their blood pressure might be low, and sometimes you can't use it. Keep them hydrated and monitor their electrolytes, because they do have electrolyte issues with hypokalemia and hypomagnesemia sometimes. Document the symptoms, and also document the improvement of the symptoms, and that helps you monitor their progress. In general, I don't treat the diarrhea that's opioid-induced because it's a great marker when the majority of the physical dependence is over, and the diarrhea will end, and usually it lasts about 3 days. So the key points about withdrawal are the acute physical symptoms usually last 3 to 5 days, and withdrawal symptoms can last up to 3 months. Now, the psychological dependence lasts longer, in perhaps greater than a year. So patients need close physician monitoring, after withdrawal for about a year at least, with urine drug screens, prescription monitoring checks, to screen for relapse. We need to screen them for substance use disorder and make sure they're getting their psychosocial support. We keep these medications, the medications for central sensitization, on for at least 1 month, And if they've been on opioids a very long time, I would slowly reduce them or keep them on a bit longer than that. Now you can wean patients 25% every other day, or even quicker or more if they tolerate it. And I find that patients who binge with their drugs can tolerate quicker withdrawals. Also, when patients come in with withdrawal, they're already halfway through their withdrawal process. So you can cut back on their dose a good amount and just titrate it to their symptoms. Now, I prefer to wean the benzodiazepine first. We already talked about that, mainly to eliminate the risk of seizures before tapering opioids. Now, also, don't forget to give them that prescription for naloxone. Now, remember, patients usually improve once the weaning process begins. Once they know that you are in line with the system and that you're not going to cave in, they will agree to be weaned. Or they can leave the hospital and go get their care somewhere else. But usually their behavior improves and they become compliant, and they can actually be very personable. Sometimes patients are so sick in the hospital, we must stop the opioids upon admission and treat the withdrawal symptoms. For example, in cases of severe respiratory suppression, and in the ICU doctors usually stop their opioids and they're sedating them with other means. Sometimes patients come in with severe rhabdomyolysis from a long lie because they've fallen in the bathroom because of their opioid withdrawal-related diarrhea and syncope. That happens. Put them in the hospital, rehydrate them, and don't restart the opioid. Now, in the clinic setting, this needs to be done more slowly, of course, but you can follow the same concepts. You may need to admit them to the hospital if they become too symptomatic. You need to use the addiction psychiatry services and send them for medication-assisted treatment if you can't wean them off opioids. But in the outpatient setting, focus on prevention. We really need to try to prevent opioid dependence from getting to this point, if possible. Confronting angry patients who need opioid withdrawal is tough. It is a test of your leadership skills. Providers need to cultivate these internal skills. So here's some food for thought to help you get started in your thinking about handling difficult patient encounters. So how do you say no? Well, first of all, explain why you're saying no, and go to the root of the request and debunk anything that they may have learned on social media or television. Offer them alternatives and engage them. Let them have a voice. Let them speak to you. You gotta listen. Be positive. Use all the patient education materials to objectify your decision. And be empathetic with the patient and align the treatment with the goals of care. And you can deflect the blame. There are lots of bodies like the CDC, the American Academy of Neurology, the Interventional Academy of Pain Physicians. All of them have guidelines for chronic pain that recommend not using opioids. And you can deflect to them. And sometimes you just have to be firm. No choice but to be firm and help them, when you do that, keep their dignity and their self-worth and their pride. Now, there is necessary suffering that must take place when patients are undergoing opioid withdrawal. The pain that they perceive is real, and it is due to brain physiology. It is not due to a new physical condition in the periphery. It's due to absence of the drug, and it usually lasts 3 to 5 days. Suffering improves over time after cessation, and you need to measure functional status to document the improvement instead of the subjective pain scale. And there is also necessary suffering on part of the provider. This is a reflection of the patient's experience. We need to recognize our own empathy and our own cognitive dissonance when dealing with opioid patients. We need to learn purposeful detachment and maintain rational decision making. Now, if you get anger and backlash, realize that we cannot escape people's anger when we're leading them through any significant change. It's just part of the process. You need to take leadership and stomach the hostility in order to stay connected to the patient and to remove them from the danger. You can set the pace. You can slow down the taper if needed. And sometimes the patients are just testing you to see if you can blow hot. If they can blow hot without blowing you away. Remember, they have attachment disorders. They fear rejection. They fear abandonment, especially abandonment by their doctor. So hold steady in the heat of action and keep the patient focused on the work that they have to do. And take the heat gracefully. That's very much essential into keeping the legitimacy of your position. Now, sometimes they emotionally attack you. These attacks are merely a distraction. This is them trying to create a diversion so that they don't have to address the real issue. Realize that people attack you when they don't like the message. It's really not personal. Rather than turn your attention inward, focus outward and maintain that diagnostic mindset. Now, these are leadership skills, and you need to lead the patient through this period of suffering. Remind the patient that this is temporary and the increased pain perception won't last forever. You need to help create that vision of a future for the patient. And remember that you're taking the heat from the patient and then you're dishing it back to him later as you steer them in the right direction. The outcomes are always better when we cooperate as a team. And this will allow us to mature into strong patient advocates. We can do this if we understand why we make these personal sacrifices for our patients. Here are some approaches to helping you to keep your bearing. If you find yourself in a battle over opioids, mentally put yourself on a balcony. Basically, in your mind's eye, look down at the scene below, at yourself as a character in it rather than part of it. Tell yourself, look at that patient yelling at that doctor. Why is she doing that? This allows you to put yourself in the patient's shoes and not feel the backlash as much. It allows you to learn how to become a Zen master. So practice mindfulness meditation. Find partners that will help you, whether it's the nurses, your colleagues, pain management doctors, therapists. You need partners. And adjust the thermostat. Keep your voice low, of course. Pace the work and make your interventions and do it firmly when you make them. Bring attention back to the issue and show that patient a different future than the one that they imagine. Now let's end this segment by saying that helping patients who are undergoing opioid withdrawal is tough work. It entails confronting patients who are angry and who are resistant to change. There is no way of knowing which patients can come off and which ones cannot. If the patient can successfully stop their opioid medication, they will have a happier, longer, and more functional life. And patients who have a pure iatrogenic opioid dependency, well, they're much more likely to be able to wean and stop their opioids, and they are less likely to relapse. Every patient deserves a chance or a trial, or to be offered a trial, to get off of these drugs that affect their subconscious brain structures before we commit them to long-term medication-assisted therapy. And since opioids affect the subconscious brain, patients are not aware of the fact that their behavior and their judgment has been affected. And they're not aware that their internal pleasure centers and that their pain-regulating centers have been compromised. These subconscious brain functions are not attached to the verbal centers of the brain. So patients tend to act out and they lose impulse control. They cannot adequately articulate or perceive what is actually happening. We as providers also need to understand our own subconscious brain function. When we interact with these affected patients who have opioid-induced psychologic and physical syndromes, we feel empathy for them, and that empathy is emotionally painful for the provider. We need to recognize our own empathy and convert it to compassion in order to steer these patients towards the right psychosocial care. And only by addressing the three phases of this disease, the physical, the psychological, and the social, will we be able to adequately address America's prescription epidemic. And remember that mantra, no new cases. That concludes the second segment of Update 2018 and Best Practices for Prescribing and Management of Controlled Substances. Now we turn our attention to the final piece of the Opioid Stewardship Physician and Provider Education Program for the Ochsner Health System. And we're going to finish by talking about diversion and red flags. Welcome back to the Opioid Stewardship Physician and Provider Education Program for Ochsner Healthcare System. We're going to complete this program with our third segment of Update 2018 and Best Practices for the Prescribing and Management of Controlled Substances. And we're going to talk about diversion and understand what that means. Diversion means the transfer of a controlled substance from a lawful to an unlawful channel of distribution or use. It also means any criminal act involving a prescription drug. Diversion can occur at any point along a supply chain. It occurs within and outside of healthcare facilities. 50% of all diverted drugs come from the medicine chest of friends and family, either stolen or purchased. Commonly diverted drugs include ephedrine and pseudoephedrine, which is used to make methamphetamines, and benzodiazepines. Now, benzodiazepines, let's talk about them a little bit. They're not good for long-term treatment of anxiety. They cause dementia if used long-term. And they make anxiety worse by increasing tolerance. And they lead to tolerance and dependence, just like opioids do. And they can affect the motivational reward system in the prefrontal cortex and other brain structures. They lead to seizures if they're abruptly stopped. Now, opioids on this list, all I want to say about that is that hydrocodone acetaminophen is the most commonly prescribed drug in the United States. We write 131.2 million prescriptions. So please reduce the number of tablets, or reduce the number of prescriptions as much as we can. And lastly, there's the ADHD drugs. For example, Adderall and Ritalin. Now, I'm not an expert on this, but just to say a few things, this is a $13 billion industry. They are performance-enhancing drugs. They are sold on college campuses all around the country right now. They do increase the risk of substance use disorder later in life when they're given to children. So we do need to rethink about what we have done and what we are doing with this aspect of psychiatric care. There is a great new Netflix video that I think everyone should go take a look at. It's called Take Your Pills, that goes over all of the issues regarding ADHD medications. This is a whole other epidemic that one day we might need to address. So remember that these drugs were invented before the disease was invented. This disease was totally made up and put into the DSM-5. So that should make you skeptical. Now, diversion can also happen in the hospital. In health facilities, Opioids are the most commonly drug that is diverted, the most common drug diverted. And this can cause great harm to the patient. Patients are left in pain. Patients can receive a contaminated drug in place of the diverted one. There are unsterile dilutions that get to the patient and that can lead to sepsis. And you can actually divert a disease like hepatitis C or HIV to the patient. Now, in healthcare workplaces, anesthesiologists actually have the highest rate of addiction, and they obtain their drug through diversion mainly. Now, diversion is a form of theft, and it's done to support an addiction or to sell. And diverters steal unopened vials, they substitute and dilute dosages, they take residual drug that might be left in a syringe, they administer only a fraction of the normal amount to the patient, and then they add water or saline to make it look like they're getting the whole thing. And they actually take discarded syringes or vials from sharps containers. Now here are some diversion examples that I got off the internet. One time a trusted visitor came and removed the fentanyl patch from the patient and put it on himself. A patient knew how to override the safety mechanism on a PCA pump and actually stole the security keys and gave himself a large dose. And then a nurse one time sewed a secret pocket into her uniform to hide the fentanyl syringes that she was taking from a GI lab. And a radiology tech actually injected himself with 50% of the syringe containing fentanyl. Then he filled it up with saline, gave it to the patient, and in that way he infected about 15 patients with hepatitis C. And sharps containers are sometimes found in stairwells. So if that ever happens, make sure you call security. Now, reducing diversion is a shared responsibility. It's a shared responsibility between providers, pharmacists, manufacturers, and distributors. We're going to talk about providers and pharmacists mainly. And there are some red flag warning signs we're going to go over. Now, responsibilities for pharmacists are, well, they need to ensure that we providers are prescribing for a legitimate medical purpose. And they have a legal requirement to contact the providers to establish that legitimacy. So they need to complete a drug utilization review, decipher illegible prescriptions, validate the prescriber's authority, and then check the prescription monitoring program. So they have a lot of work to do, and that's why they call us a lot. Now for physicians need to complete a proper evaluation, and they need to follow evidence-based prescribing. And they need to screen for diversion and non-medical use. And they need a good patient-physician relationship when they're prescribing opioids. Now for diversion prevention, first of all, you need to recognize diverters. Doctor shoppers are the biggest group of diverters. And the second biggest group, believe it or not, are the elderly. The elderly divert because they have economic reasons. They are poor, and they divert into their neighborhoods usually. And some of these neighborhoods actually have pill brokers. They actually go around, find elderly people in the neighborhood that are willing to go to the doctor and to see their physician. And when they do this, they target older physicians. And then, of course, there's the family and the friends who actually divert their leftover tablets or sell them. Now, to prevent this, we need to reduce the number of tablets that we give. We need to know who our patients are. We need to use alternatives first. We need to do proper risk assessments for misuse before we start or give opioids out. We need to follow evidence-based practices. We need to use shorter duration of treatment for acute pain. And we need to recognize misuse and stop controlled substances when we find it. That means we need to be brave. And so if you're going to engage a patient and tell them that you recommend that you're stopping the substance that you've been prescribing, get help. Get your nurse to come in with you. Get another provider to come with you. Make sure you Document the reasons for doing this ahead of time. Understand that some drugs have more abuse potential than others, and choose the ones with the less abuse potential.
So how do you report diversion? Well, at Ochsner, we are hiring a drug prevention program director, and he will be a compliance director, and he's going to develop and lead our anti-diversion program in the future. We have a controlled substance diversion policy that outlines responsibilities. So if you encounter diversion, make sure you immediately report it to your supervisor, your unit director, the charge nurse, or your department chairman.
And for substance use. Patients who travel far and then request a substance on the very first day, you have to think that they might be wanting a prescription so they can divert it. And patients who come in groups and they all request a controlled substance. Patients who are sedated, confused, intoxicated, or exhibit withdrawal symptoms, or have physical signs of abuse. So that's a red flag that they are opioid addicted. And multiple unexplained dose escalations. If you're seeing a patient and all of a sudden they need more and more of their opioid, that might suggest that they are diverting some of those tablets. And non-adherence to the treatment plan. I had a patient once who would not do his wound care. He was actually fired from another healthcare system, came to us, and he would go home, neglect himself, just so that he could come back to get his IV pain medication in the hospital. Use a route of administration. If they use a route of administration that's other than prescribed, that's definitely not a good sign, a red flag that they're not, that they're opioid dependent or addicted. And if they seek medications from non-coordinated sites of care, like the ED or urgent care or walk-in clinic, well, that's a sign that they could be diverting tablets. If they have an unintentional overdose, this might be because they're not taking their medication as prescribed, and they're actually giving tablets away or selling tablets. Then they go back to their medication and they have an overdose. So that's definitely a red flag. And if they have a PMP report, or if their behavior suggests that they are obtaining prescriptions from multiple sources without the provider's knowledge of the other providers, that's certainly a red flag that they could be diverting drugs. Some more doctor red flags. If they're discharged from another physician for bad behavior, if the patient pressures the physician prescribed, if they're making direct threats, it's definitely a red flag that you should not prescribe opioids to them. If the patient resists change in the treatment plan, despite clear evidence of adverse effects, that's definitely a red flag that they are opioid dependent, or that they are, trying to get more drugs to divert. And if they refuse to sign an opioid agreement, they refuse to sign the contract, it's definitely a red flag. And for patients who request that the prescription be written in the name of someone else, make sure you know that family. If that happens, that is definitely a sign of diversion. Now, pharmacy red flags. Sometimes patients will travel in groups. They'll have the same script from the same provider. That's definitely a worrisome sign. And patients may have a script that's written for someone else. Patients will present a script that the pharmacist knows was declined in another pharmacy because they checked the computer records. That's definitely a red flag for diversion. And sometimes the script will look altered, so that's definitely something that's to be concerned about. And if the pharmacist is aware that the provider's DEA was revoked, that is also a red flag. Now, there's some more pharmacy red flags. The patient presents the same script to multiple pharmacies. The has scripts for highly abused controlled substances. The patient may have several scripts, but they only want the one controlled substance. If there's a history, if the pharmacist actually knows the patient and there's a history of untruthfulness when filing controlled substances prescriptions, if the patient presents scripts for large supplies, it's definitely a worrisome sign for diversion. And if the patient has scripts for cocktails, like the opioid, the benzo, and the muscle relaxant, that's definitely a red flag. Now, what is the illegal or illicit behavior? If the patient indicates that the drugs are going to be sold or shared, well, that's illegal. The pharmacist can't dispense that medication, and the doctor should not prescribe it. If the prescriber's DEA number or registration or state license was revoked or suspended, well, then the pharmacist can't dispense that medication. If the prescriber is writing a script outside of the scope of their practice, well, that's illegal for the prescriber. And if the patient alters or forges or sells or rewrites a prescription, that's illegal to the patient. And if the patient is diverting or selling or getting drugs from others, well, that's illegal to the, for the patient as well. So here's some tips about aberrant behavior. Always look for multiple behaviors, because the more you have, the more likeliness of abuse. And you need to look for a history of aberrant behaviors. Follow them over time, multiple visits. One behavior does not confirm substance use disorder. And aberrant behaviors need to be taken in the appropriate clinical context. Now here's some clues that aberrant behavior is taking place. Patient might be coming to you for the first time, and they appear to be faking or exaggerating their pain severity. There may be excessive emotionality. They may offer only a vague medical history. They may bring their own medical records to the visit. They will not provide the name of the previous physician or the name of their psychiatrist. They may have unusual knowledge about their opioid medications. They may use the street names or request large quantities or specific drugs. Or they may be verbally abusive or have aggressive complaints. And sometimes they insist on paying cash even though they have insurance. So that might be an aberrant behavior. More aberrant behaviors: losing a script, claiming that a script was stolen, a pattern of early refills, using the drug without approval, for other symptoms, drug hoarding, a claim of allergy, refusal to taper the opioid when the pain syndrome is over and it's indicated, concurrent use of alcohol or other drugs, and then non-medical uses of opioids, like using it for a coping method, intolerance to alternatives, and refusal to try non-opioid remedies, and refusal to engage in cognitive behavioral therapy or psychosocial care or rehab or physical therapy. All these things are aberrant behaviors. Now, remember to assess aberrant behaviors in the appropriate clinical context. Patients do sometimes travel far to specialty clinics, and patients do get familiar with their medications in chronic disease states, and they may lack understanding of what a true allergy is. So look for patterns over time and look for a history of disruptive behavior. These behaviors are patient-specific and they need a differential diagnosis.
Okay, so this last section is part 4 of the Opioid Stewardship Physician and Provider Education CME program. This part was added in September 2019 because the State Board of Medical Examiners wanted us to make sure that you receive this information. It contains sections on medication reconciliation, a review on essential documentation, and the 2009 American Academy of Pain Physicians guidelines on properly prescribing opioids. The Controlled Substance Act was passed in 1970 in response to the heroin epidemic of the 1960s. It created 5 major classes of drugs, or 5 schedules or classifications. The FDA and the DEA determine which substances are added or removed to this list, but Congress can also add or remove a drug by separate legislation. This act satisfies key treaty agreements that we have about international drug laws, making sure that we keep our Constitution the supreme law of the land. So I'll let you just go through and read the next 6 slides that reviews the Controlled Substance Act. Medication reconciliation is critical for communication amongst providers on what the patient is taking and what they have been prescribed. It keeps everyone, including the patient, on the right page. We need to do the tedious task of getting the dose, frequency, and route of administration correct. Medication reconciliation was named a National Patient Safety Goal by the Joint Commission. The poor communication of medical information is a major source of errors. We want to prevent adverse drug effects at all transitions of care because that's where most of these mistakes occur. We need an ongoing list of all the medications that a patient is taking. We need to actually compare the current list of medications against what the patient is bringing to you in the clinic or into the hospital, and then reconcile any differences and make sure it's correct. This must occur in a standardized manner. This is a key reminder of essential documentation for prescribing opioids, which we reviewed earlier in the course. We need to document that we have completed the risk assessment, checked the opioid risk tool, the PMP, the urine drug screens. We need to document that alternative treatments have been failed and the reason for using an opioid medication. We need to document that we're doing their medicine reconciliation and have an opioid agreement or a contract for chronic pain patients. And we need to document the monitoring and progress of our patient who is on ongoing opioid therapy. That means their functional status, their subjective pain response, their observed adverse effects and side effects, and their aberrant behaviors. If we see aberrant behaviors, we need to document them in our notes. And of course, weaning and cessation recommendations, and then getting them through that should be documented as well. Here's a review of appropriate monitoring and follow-up of patients on prescribed opioids. If you've given them a short-term prescription, we should be looking for the resolution of their pain. And for long-term prescriptions, we need to monitor their functional status, screen for substance use disorder, screen for worsening pain or analgesia, and screen for opioid dependence. We need to put them through tapering protocols on a routine basis whenever we prescribe long-term opioids and just make the decision to taper. You can wean 20% every other day or even quicker as tolerated depending on symptoms. And also we need to monitor for noncompliance or signs of aberrant behavior, diversion, and hoarding tablets. This last part of the lecture is a review of the 2009 American Academy of Pain Physicians and American Pain Society recommendations based on a literature review on how to properly prescribe opioids. The State Board of Medical Examiners wants you to have this information. There is a link to a good review article right here. The American Academy of Pain Medicine's literature review makes recommendations for monitoring, tapering, discontinuation, duration, and initiation of opioids. It's an attempt to make recommendations about proper prescribing. But I'd like to make a couple of comments. Most of these recommendations are based on low-quality evidence, and there's very little to no long-term data on prescribing opioids for chronic pain. And to really be unbiased, the opioid literature should be reviewed by a group of clinicians that includes a broad array of professionals, such as critical care doctors and hospitalists, primary care physicians, and addictionologists who treat the complications of addiction. We need higher quality research to know best practices. So with that, I will let you read through the rest of the slides. Thank you for taking the Opioid Stewardship Continuing Medical Education program. I hope it helps you in your practice.